thanks. Should I make it softer?
No, this is very clear.
Okay, thank you.
So Thomas, you are in the name of Nitin K?
No, I'm in the name of Spear India.
Okay. It's 3 o'clock, Thomas.
Yes, sir. Anyways, let's start our session.
Yeah, so if Professor
Santosh joins us soon.
We can take him after Dr. Pavitra Mohan.
Okay. Sure, sir.
We can wait for a minute if
so
it's already 3-1.
Let's start our session. I request any of the co-hosts to please let all the people waiting in the waiting room get in. Oh, Professor Santosh is here. Professor Santosh, in the name of Santosh Kumar, is here.
So let's start, Thomas.
I was just making him the co-host once. I've given the unmuting rights only to the co-host. So yeah, let's start our session. Welcome once again to our...
Thomas, just a minute. Just assign responsibility for one of your team member to admit all those who are joining.
Yes, sir. I've already told them they would be doing this.
Okay.
Shall we start, sir?
Yeah, please go ahead.
Okay. Okay, welcome once again to our webinar on care of newborns at home. I would like to welcome our moderator for the day, Dr. Sridhar Yavanki. Dr. Sridhar brings over 9 years of experience in public health. He is a medical doctor with Masters in Preventive and Social Medicine, MD, from South Gujarat University with University Gold Medal, trained by University of South Florida on advanced clinical epidemiology and biostatics, and trained in health economics. For 4 years, he has contributed to UNICEF mission as health officer in Assam office, and since April 2020, he is working as health specialist for UNICEF Chhattisgarh. I will now hand this over to Dr. Sridhar Yavanki to welcome and introduce all our panelists for today and also take the session forward. Over to you, sir.
Thank you, Thomas. Thank you so much for that wonderful introduction. So we have a packed session for today. I welcome on behalf of UNICEF and Against Peer India to all the participants and all the panelists for this wonderful discussion happening today. We had a rich discussion yesterday on kangaroo mother care. So this is our second webinar in the series as a part of celebration of National Newborn Week nationally. So before going into the agenda, I welcome Professor Santosh Kumar sir from National Institute of Disaster Management. He is a disaster risk reduction, policy planning and capacity development expert with 25 years of experience in different positions in development, planning and DRR sector. He's a PhD in economics. He studied gender and development in UK and received professional training in disaster management from Israel. He's back with international experience working at World Bank, intergovernmental body of SARC. He has also worked at state level in different capacities in UP Academy of Administration, Nainital, and RIP ERIPA in Jaipur. We are very glad to have you here, sir. I request Professor Santosh Kumar sir to give the inaugural opening remarks.
Thank you, Dr. Sridhar, for this particular moment when
Welcome,
you
sir.
invited and given an elaborate kind of introduction. But first of all, I would like to compliment you and entire team of UNICEF and Sphere for holding such an important kind of a webinar or on the eve of this, on the occasion of National Newborn Baby Day or week you can say. And newborn baby care at home is a very, very challenging kind of a topic as a kind of a DRR professional when I see. I would just flag a couple of things, and I'm not this expert basically in going into the details of the child care. But I take this as an opportunity to flag issues related to what kind of a situation when children, the newborn baby come into when the society faces various disasters, especially when we face the floods situation, the earthquake, tsunami, cyclonic storms, and this COVID-19, which we are facing as a pandemic. And when we say newborn baby is their vulnerability that they are dependent. They are not kind of independent in themselves. So it's important to look at how vulnerable are whom they are dependent, and what kind of this kind of it will bounce back to them as a kind of independent on whom they are dependent, and they are weak and not able to manage them properly. This is one. Second, when the early warning system is given or early warning is given to the society for evacuation, that certain situation is emerging and large number of people to be evacuated. So during that time, how the evacuation process, taking care of the evacuation of the newborn baby, their safety, their kind of a requirement on a daily basis, hourly basis, you can say, and how that is ensured by the interventionists or the governance of the DRR. The third thing which I would flag is that when they are evacuated and they are put in the camps, on the relief camps, and what kind of facilities which we have for the newborn baby in the kind of a large number of people when they are evacuated and put in the camp. Fourth is this, that issues related to the connected one, their requirement. If the dependent on whom the children are dependent, if they get affected seriously by disasters. Not I'm saying about the fatality in terms of deaths, but if we are saying that if they get grievously hurt, then what will happen if they are not able to care themselves, then how they can care, or who will provide that kind of a service to the newborn baby in the family, because we say that their voices are not there. So how to recognize their need, how to understand those challenges and how to address them at the time of disaster. Seeing this, that all nutritional care and also the hygiene care and also that vaccination process which has to undertake during the time of, if some certain dates are falling during the time of disaster, and how that is going to be ensured. And when the health response is there from the health department, along with the revenue department, which takes care of the response, what kind of arrangement do they make, whether they are aware about those kind of a need and is emerging. And so both ways we have to see that the larger context, how their vulnerabilities are reduced. And if their vulnerabilities are reduced and taken care of, well, definitely we are going to have a healthy child or healthy child induction in the kind of a entire family and the society and the nation as a whole. So this is a very typical circumstances when they have mother and the children both are vulnerable during that time. So how they can be protected and what kind of intervention or what kind of a public policy do we need so that they can be protected, their interests are protected, their lives are protected, their futures are protected, so and so for these other issues. And now the last point which I would like to mention in terms of the COVID-19. What happens in COVID-19 if the mother get affected by COVID and is found positive? Then what will happen to the newborn baby care in the family? How the newborn baby could be, whether issues related to breastfeeding, or what kind of a myth which we can break, and what are the reality which persists, what are the information it has in the public domain, where this, if such kind of circumstances do happen, then what are the things already available and that can be taken care of, for which we need to worry and for which we don't have to worry. So if that kind of a do's and don'ts are also there, that I have spoken to many lactating mother, and also that those who are, they are worried, and if they get affected by COVID, what will happen to the baby, newborn baby? So baby care, in what, where to keep them, how to keep them, and there are many other. I'm just pandemic and long other disasters which I'm saying, but there are many other elements gets combined with this. So how these vulnerability can be reduced as a kind of an ex-ante investment, how we can build our system pre-disaster scenario itself, so that even if this kind of a disaster happens, the impact on the newborn baby is minimum. So that kind of a scenario, I don't know whether we have a quantified kind of an impact on them, that in what way they get affected and what are the things which is the area to be addressed. And then definitely it would also help us in integrating what we say, that integrating disaster management in the health service providers. But we also looked at what are the essential of health service providers can be integrated in the disaster risk management. So both ways, that is important, that how we should be looking into our whole response, where our state disaster response force goes to the affected area, or national disaster response force, what are the appropriate behavior for them, and especially tackling the newborn baby. So those kind of things which we are really, if we wish to make as a kind of a very, very newborn baby friendly disaster response, disaster relief, and then also disaster risk reduction system. So these are the points which I wanted to flag. Thank you very much for giving me this opportunity. I thought that I would flag and listen to the experts, what they are saying in this area. Thank you, Dr. Sudhir, for giving me this opportunity.
Thank you, sir. Thank you so much. And thank you so much for bringing this important issue and highlighting this to our audience. So definitely during disaster, as you highlighted, mother and newborn are especially vulnerable. And it is not only evacuation as a general population, but the safety of them and continuity of services for them, because their requirements are very specific. And especially now during the times of COVID-19. Thank you, sir. Thank you for your excellent highlights. And I think it will benefit our CSOs to plan their activities with this context in background. Thank you, sir.
Thank you very much.
Yeah. Friends and colleagues, I think we have a very packed session for next 90 minutes coming up. So we have basically 4 sessions. The first session is about the continuum of care for newborns at home and at the facility. Second is we want to talk about the particular components of home-based newborn care and what precautions we need to take, especially at the times of COVID. And then we have experience sharing from senior health officials from the state of Chhattisgarh, the largest community volunteer program which the state is implementing. And at the last, we have some discussions on urban challenges in newborn care. So this is the brief of today's agenda. And we will start with the first session. And I have immense pleasure to introduce Dr. Pavitra Mohan. So many health professionals in India derive inspiration from him, including me as a young health professional. He comes with a unique package. He is a pediatrician from Delhi University. He is a master's in public health from University of North Carolina, and he is also a community health physician. So we do not get such a unique combination, and which is more essential for public health in India in these days. He is a co-founder of Basic Healthcare Services, a non-for-profit organization that provides low-cost, high-quality primary healthcare services for the marginalized population in South Rajasthan. Dr. Mohan also serves as Director of Health Services at Ajivika Bureau, where he leads the designing and implementation of solutions for improving health of families that are dependent on labor and migration. Earlier, he was our senior health specialist at UNICEF India Country Office, and he has designed and led many large-scale health programs for this country to improve the maternal, newborn, and child health in India. And recognizing his contribution, he was inducted as a fellow of National Neonatology Forum of India in 2010. And with his immense contribution for newborn care in India, he has been awarded the prestigious Ashoka Fellowship for Social Entrepreneurship. We welcome you, sir. We are glad to have you today. Sir, are you able to hear? Can you unmute yourself?
Yes, I can hear you, Sridhar. Thanks for that introduction.
Sir, we have next 20 minutes for this discussion. I'm going to touch upon two key areas of discussion with you. Sir, you know, India has made a good progress in reducing the neonatal mortality and infant mortality since we introduced the India Newborn Action Plan in 2014. And for the first time in India, we have the total number of child deaths coming below 1 million per year. And that is a great achievement for India. And now we are moving from Millennium Development Goals to Sustainable Development Goals. And for newborn care, especially, if we talk, the major shift is from survival to development. But still, India, the survival is still a challenge because still we have a high number of newborn deaths happening in the country. Along with the survival, we need to ensure development. So in this context, sir, how do you ensure there is a continuum of care from the facility to the home for newborn survival, growth, and development? We have a lot of initiatives at the facility level. India has progressed a lot, but to achieve towards this SDGs, how can we ensure this continuum of care? Over to you, sir.
Thanks, Sridhar. And it's it's a long question and it's a difficult question. I would just, begin with a few perspectives and then we'll go to a bit more specifics. In India, while there are, as you say, the continuum of care from facility to home, it's not one way, and there are multiple pathways to it. About 20% of childbirths continue to happen at home in India. And a large proportion of the remaining neonatal deaths, as you say, while there has been a huge decline, there are still, the larger number of deaths are concentrated amongst those who are unfortunately not even able to reach hospital for childbirth either at all or in time. So there, the pathway is different. So you're born at home, but then, if you're sick, might ever be taken to a hospital and back to the home. For those, and the journey actually starts earlier during even if we are conservative, it starts during pregnancy and how the mother is cared for during pregnancy and how her nutrition and her anemia levels are. Which is often so, and that care is done variably at home or in outreach sessions or in a hospital, the care during pregnancy. Then comes the childbirth, which, as I said, that while a large number of childbirths in India happen in hospitals, but there's still a fairly large numbers who continue to happen at home. And then, of course, after the birth, there is care both at hospitals in many cases, but then there is also a large component of children who are then subsequently cared for at home. So these are multiple pathways along the journey of a newborn. Even if we start from conception to the end of the newborn period and subsequently. Kanunika asked me to share some photographs, so here they are. And while we're beginning with childbirth here, and these are the immediate newborn period, where one of the reasons why I picked up these slides is that it is a joyful occasion, and it's the first time that probably the only time where one person becomes two in some ways and start living with an independent existence. And as you see in the slide, there actually one becomes three because it's a twin babies who of course are lovely to look at, but are low birth weight and have would require intense care both in the at the time of birth, but also at homes for chances of survival. And this the next slide, please. Can I? Okay, I think I can handle the slides from here. Okay. And this picture again I picked up only to show that that childbirth is a joyful occasion, and the baby, seeing the existence of a newborn baby requires a lot of care both at this time and subsequently. Is somebody else handling the slides, or I can? Okay.
Sir, I am here. If you want, you can handle, sir. I'll leave it.
So
Okay.
can you just put it on full screen, sir? It's not coming full screen.
It has to be full screen, Dr. Sridhar.
It is on full screen.
No, we are getting the next slide mode. So you have to change the PowerPoint mode to the full PowerPoint slide.
Yeah, I have put it in a slide. Is it fine now?
No,
it's still not full screen.
Slide sorter view has to be changed, Sridhar.
Just a minute.
So that there you can see only the current slide and not the next slide. Currently, we are seeing both current.
Okay, okay. I'm not finding the option here.
Close it, reopen it, and then just select the
Fine now?
Okay, maybe we just kind of, I'll continue. And
Shall I
maybe
share the screen?
Is it fine now? Now I made it full screen.
yes.
Yes.
Yes, this is fine.
Yeah.
The next one,
Please, sir.
Yeah. So, so the continuum, which I said at the earlier, even if we do not consider the preconception period, we start with pregnancy. Childbirth is an important milestone, which can be at hospitals in most settings and at home in others, and which is a period of immense requires immense need and care, but also is a joyful occasion. So, next one, please. I think there is some problem with it. Okay. Yeah.
It takes some time, sir.
Okay,
Takes a
It
minute.
takes 2 seconds.
Okay, not a problem. Sorry. Yeah, and I was, I just wanted to share this photograph because it's something that was captured by one of our health workers while on a field visit. So this is a baby being cared for and weighed, and on the backdrop you can see a Food Corporation of India's wheat, a bag which is a wheat, and it struck me because a large number of people, in terms of continuum of care after the newborn period and once the breastfeeding, exclusive breastfeeding is over, there's very little food and very little food that is provided to the child, and that's when they start getting malnourished. But in this case, having a wheat bag in the backdrop is a reminder that they would require adequate food as they grow up. Next one, please. In the immediate newborn period, some of the basic things that newborns require are warmth and care and feeding. They actually require very little to grow in the initial period, but to ensure that requires care, which is often at the household level, provided by a wide range of healthcare workers. And it is one of the examples of how primary healthcare, by task sharing, allows care to be provided to large number of people in remoter settings. If, for example, postnatal care was only meant to be provided by a trained pediatrician or a neonatologist or a nurse, it would probably not have reached the scale that it has, and such large number of children would have left uncared. But here, the family and the front worker together provide care to the children in initial few days, and that's where home care becomes extremely important. What you can see also on the backdrop is the grandmother cooking food for the mother, which is again such an essential part of what you do at the home level to ensure that the mother has adequate nutrition, and also that the other family members are involved in the newborn care. I think something that we often miss: the care of the newborn is not only responsibility of the mother, and it's actually not only dependent on the mother. And home care provides an opportunity to be in the home setting and engage other family members who are responsible for care of mother and for the newborn. Next.
So this is a very interesting picture, sir, you are showing. I just want you to explain what is that health worker is doing, sir, for our audience.
Okay, so as I said, that one of the important things in the initial periods of the newborn life, when you provide care at home, is to weigh the baby. And weighing helps you to know few things. One is whether the baby is low birth weight, and does the baby require a referral. And the second is if the baby is growing well and everything is fine, if the baby is growing well. And here a frontline worker, in this case, our community health worker, is weighing the baby to ensure and to reaffirm. If you look at the mother, she's looking very carefully at the readings that is my baby normal weight or low birth weight. So it is also reinforces the mother's confidence that the baby is being taken care of and is growing well. On the other hand, there is, as I said, the grandmother who's taking care of them. Next one, please.
Sir, we have this health worker who just has a basic qualification. So do you say, sir, as a neonatologist and pediatrician, if you do a small bit of training, even such people can provide newborn care at home? So that is that message you want to give it to our CSOs audience who are here?
Absolutely. So I think in primary healthcare, one of the important things that how do you demedicalize care and bring them out of the I would say the clutches of pediatricians and specialists and of hospitals. I think, and another thing that is COVID-19 has shown very, very clearly and forcefully is that care which is very centralized and which is very specialist based can very soon become inaccessible. It was always inaccessible to people living in the communities that I'm talking of, which are remote and rural. But in COVID-19, we realized that even people with means also suddenly found themselves without transport, without being able to reach specialized care or hospital-based care. And as all of us know, that very large number of childbirths, which earlier would have happened in hospitals during this period, were out of reach for a lot of people. And therefore, how do you decentralize healthcare? And one of the important things of decentralizing healthcare is by equipping non-doctors, frontline health workers, and other providers, and finally family members to take care of a lot of to provide a lot of healthcare. And that makes care closer to people. It is more empathetic. For example, the worker here comes from the same community, so is able to, and with some additional skills, can provide bulk of care.
Thank you, sir.
The
So
next
please
one,
continue
please.
with your next.
Yeah. The next one, please.
I have
Just to again re-emphasize the focus on mother. I mean, in this picture, what struck me was the mother is really looking straight and clearly and forcefully, and basically asking that she also needs care. And therefore, I think one of the things that we often break them down into care of mother at newborn at home or care of newborn at home, while at this point of time, as in other points of time, the mother requires as much care as the newborn, and therefore, home care also provides that opportunity to look at the mother if she has any other health needs or information needs on how to care for the baby, etc. And that continuum also means that at different points of time, the mother would have different needs for herself and for her baby. For example, in the initial period, she may have a lot of apprehensions about how to establish breastfeeding, how to continue breastfeeding. She may have questions about herself, or what to eat, what not to eat, how to, when to bathe, etc. And then subsequently, the needs would change to more of exclusive breastfeeding, recognizing danger signs, etc. So caring for the mother and baby as a dyad and not looking at them in isolation is something that's important during the early days of life when providing care at a household.
This is a very important point, sir, you made. I think a mother is the first neonatologist, and we need to see mother and baby as a whole for when we look at newborn care.
Right. And home-based care by frontline workers allow that to happen.
Yes, sir. So next pic
next
is
one,
there
please.
in front of you.
So I just wanted to show this slide because I really like this one, because you can see a wild, barren, open field and a hill behind. And during COVID-19, when it was difficult to provide care, without, especially care which required getting close to the person. At the same time, newborns can't wait. One could not stop doing newborn care. So in those days, providing this care in the a bit in the open and a bit distant and still keeping safe, but it continued, and that's the beauty of community-based care, that it is easier not to interrupt it, and a lot of things can happen even when because care is being delivered at the household level and in the community settings. So continuity and uninterrupted care is more possible. And this also shows beautifully the community worker who comes from the similar community. She's happy, she's smiling, and others are also smiling along with her. So the huge value of a community health worker or a community person to provide care. It is more empathetic, it is more joyful, and as Sridhar had said, that they can be skilled to provide quality care.
Next pic.
So just kind of reinforcing the same things, that at a household level, there is another child whom you can see in the backdrop, and she may have other needs as well. So when you provide care at a household also look at the other needs and members. Next one, please. Next one, please.
It's visible, sir.
Yeah. This was only to say that, in our programs in general, we expect ASHAs, or only the community health workers to provide care. But it is also useful to have A&M support and supplement, the care at home, and not become a passive, passive partners in providing care. So all those who are available at the community level, it is useful that all of them are involved together. One of the ways we ensure is that the ANMs also participate in the care.
Your voice is breaking, sir.
And they also, just give me a minute. I'll try to see if I can fix it. Is it better now?
Yeah, perfect, sir. Please go ahead.
Okay. So it is important to have there are limited number of healthcare providers at the community level, and having ensuring that they are aware, they understand the continuity of care, and therefore the nurse who is also responsible for providing care at birth, if they are also involved in some ways in providing care at the home, a continuity of relationships and continuity of care is provided. There have been some questions that I'm reading. I don't know, which are around the weighing and is it a hand weighing scale? So we can probably discuss that a bit later in the question answer session. That what kind of
Sure,
scales are there? More technical in nature, I would not. Okay, can you? No, I don't think one can. No, just the previous one.
This one, sir.
It's a video actually. Can you play it if possible?
Excuse me, sir. Sorry to intervene. We have 5 more minutes to conclude this session.
Sure.
Thank you.
Yeah, Thomas. Another 5 minutes will conclude. Sir, video is on.
Okay. I was showing this video only to say that at home, one of the important tasks that one does is recognition of illness in a newborn, because this is a period where there is a high risk of infection and other hypothermia, hypoglycemia, etc. And in this case, the baby was found to be septicemic and identified at the household, and therefore the continuum of care from home. So the child was delivered at hospital, at health facility, brought back home. At home was identified to have illness, and then therefore again brought back to the health facility for further care. So this continuum, as I said, it's not one pathway. There are multiple pathways possible, and it can only happen in a well-functioning primary healthcare system where the facility and the community workers work in partnership and in consonance with each other. The next one.
Next pic, sir. It's visible, sir.
Yeah.
Yeah.
So once the immediate newborn period in the first week or so, first few weeks are over, then there are other needs that the newborn has, and of course this is beyond the first month of life. But as we often use the young infant up to 2 months, there is the need for continued care for immunization, for example, and again a well-functioning primary healthcare system then takes over and provides vaccination, as in this case. Next one.
It's visible.
No, not yet to me. Yeah, no, it's visible. And this is a baby who's grown up, and I really like this photograph because it's not often that I also do reinforce the fact that fathers need to care for the babies as well, and a good a healthy newborn and a healthy child is often dependent on care from multiple from at least both the parents, and the father's role in rearing up newborns and children is extremely important, and then it grows into a healthier baby. So these were this was only to demonstrate that from the conception to childbirth and then continued care during the early period, there are multiple points at which care is done at home and multiple points where care is done in a facility. And in a well-functioning system, both of them are important and need to talk to each other to be able to take through a baby with a very vulnerable period during the early life. Yeah.
Thank you, sir. Sir, we have another 5 minutes to wind up. And just sir, quickly, can you share your experience? Because you run this comprehensive primary healthcare program in South Gujarat. From your personal experience, can you share how this helps to strengthen the newborn care in the community and at large for the country?
As I said, that in a well-functioning primary healthcare system, like where we run, I would take maybe one or two examples and only to explain how a comprehensive primary care is useful, which has multiple domains to it. For example, there was this woman who delivered at home, and we received a phone call to say that the woman has delivered. It was a precipitate labor and the placenta hasn't come out. So one of our nurses went home and the baby was actually just lying hypothermic. So she ensured she did the uterine massage, etc., and ensured that the placenta is delivered. The baby was wrapped up well, ensured that the baby was warm, and brought to the health facility. Realized that the baby is low birth weight and septicemic, and therefore was referred with escort to a tertiary hospital where the baby was kept in a newborn unit and then revived and came back after 8 to 10 days. So what this story tells is several things. That one is there needs to be a communication and a trust and a contact between the communities and the facilities. The facilities need to be equipped to provide care not only within their 4 premises but also in the communities and at household. We need to be equipped with a referral mechanism that ensures that the care is, at the next level of care, if required, is provided when it's essential. And therefore, a well-functioning primary healthcare system would not only strengthen the healthcare in general, but would also be good for my maternal, newborn, and child health. Many times there's this discussion around focusing on newborn care, right? Or focusing on primary healthcare. These are not two different things. A strong primary healthcare system is good for everyone. It's good for mothers, it's good for babies, it's good for fathers. It does, of course, the challenge is that how do you integrate different levels of services? And I think focusing on a strong primary healthcare system would ultimately ensure that there is good care for mothers and babies in an integrated manner along the continuum of care, along the life cycle. Any fault at any of these levels could have resulted in the baby's outcomes being adverse. I also remember another story where a woman with a mental condition came and delivered in the hospital, but because of her condition was completely disinterested in the baby, was not able to feed. And a regular effort by the nurses at during the hospital stay, as well as in the community continuously through the A&Ms and just being at home, helping the mother to recover, to support when it was most required, ultimately led to a situation where both the mother and the baby, completely slowly. So what it requires is to be responsive. It requires to be closer to the communities. It requires trust to be built. All of them are characteristics of a primary healthcare system. In absence of that, merely technical interventions of a certain kind will not help. So I think a trust, a communication, a responsiveness to the needs of it being more need-based rather than intervention-based is what ultimately works in a primary healthcare setting.
Thank you, sir. Sir, we don't have much time to take questions, but we have 2-3 people in the chat box asking about that scale which is used for weighing.
Okay.
If you can just briefly explain about it, we can conclude the session.
It's a standard handheld scale, handheld spring scale with weights in grams and also color coded. So it's a simple spring balance, handheld spring balance, which is used widely for weighing babies. The advantage being that it does not require a stand to hold it, does not require a battery, or reasonably helpful in weighing the babies in the newborn period. I can share. I mean, if somebody is interested, I can share the specifications.
Sure, sir. I think the participants can share it with Spear India, and through Spear India, we can share it with the panelist for any further questions. Sir, we have a comment from one of the participants that when fathers initiate the care, it is more effective and helpful for the mother, as he is the decision maker family, as you rightly pointed out. We have one question from Dr. Kaninika. She's asking, is Asha the ideal person to provide home-based newborn care, or can there be any alternative? What are your thoughts on that?
My thought, Kanika, is in every other thing is that ultimately it is a team approach, and I think we have limited resources at the cutting edge in primary healthcare system, and I think using them judiciously is extremely helpful. So I would think that while Ashas have a huge role in newborn care, they also need support. They need support of auxiliary nurse midwives in many cases. They may suspect that something is wrong, or many times in our cases, Ashas come and say that this woman doesn't listen to me. So just the fact that there's somebody else who comes and supports them at the household helps in identifying the problem. Maternal, if it's a well-functioning primary healthcare system, then of course, one of the concerns is Ashas cannot, it's difficult for Ashas to identify some of the maternal complications in the postnatal period. But that's where, a team approach, a task sharing and not a task shifting approach, where you share certain people, and when you are not certain or you need more help, you engage and bring in others in the ecosystem. So I would say that Ashas are extremely useful to provide because they are the only ones whom we have at the community level. There are other community health workers or volunteers who are equivalent in certain settings. But do you require a slightly higher level of skills to manage certain or identify certain complications in the community, for which ANMs and nurses in the PHC or the physician
We are losing you, sir.
They're all kind of a bit mobile and bit. Is it better?
Yeah, it's better. Now it's audible, sir.
Yeah. So I think Ashas is an important, and any other community health volunteer is an important person in the whole newborn care at in the community setting. But they need to be, I think, in stand.
We are losing you again.
Probably nothing. Let me just change my.
Yeah, now it is audible.
Okay.
Sir, we have many questions coming up. Quickly in one sentence, if baby is hypothermia, how will we transport the baby in the community? Because there is no facility for newborn transfer. What about vaccination during pandemic COVID, because our PHCs are closed? Cost of the newborn weighing scale shown in the presentation. This is by Dr. Nikhil Karod, sir.
Okay, I think some of them I'll probably need to answer later, but I think the transport, transporting baby with the mother, providing KMC on the way is the best way to transport in our experience, to transport the baby with the mother during referral, as it is for providing warmth even otherwise even within the health facility. So for transport also, I think ensuring that the mother is transported along with the baby and providing KMC is the best way. What was the second question, Sridhar?
The cost of that weighing scale, sir.
I'll need to check. I think it's about 400 rupees or something.
Okay.
We'll share the specifications and the vendor details, etc.
They were worried about vaccination, sir. Vaccination.
So I mean, in our case, again, I think one of the problems of centralization is that there was one order that you don't vaccinate and nothing was, and the facilities were closed. What we decided was that after a month, initially, of course, one was still running. What we decided is that we will bring smaller number of mothers and their babies to the health facility and we'll vaccinate them there in the open one by one. So we started scheduling appointments for vaccination. So after a month, we actually resumed vaccination. So I think it is only a question of being more responsive and a bit more decentralized decision making. A centralized order saying that you can't vaccinate. I think if the order was that ensure that there is no transmission, ensure that there's no crowding, would have been more worthwhile. And that led to unnecessarily restriction of vaccination in very large number of places. So.
Okay, so last question from Vandana. She is asking, it is a big question, but I'll just take a component of it. So now under health and wellness centers, we have community health officers at the primary healthcare level. So do you think they can play an important role in providing quality of follow-up of home, continuing in the continuum of care from home to facility?
Absolutely, Vandana. I think everybody, as I said, that it is ultimately a team approach, and we should not look at health and wellness center or the community health officer also in isolation. They are part of a primary healthcare team where everybody has a significant role, and if they work together, they will find their right fit on how to support each other in providing optimal care. The danger would be if we start relying on CHO now instead of everybody else in the team. If we consider
Yeah.
them as part of the team and they work together to deliver, that would be the ideal situation.
Thank you, sir. Thank you so much. We have
Yes.
taken 10 more minutes of you. Thank you for bearing with us. We have
Okay,
many
thanks,
questions.
Ashish.
If possible, we will share this chat and then we'll get back to you for any questions. And thank you so much.
Thanks.
So continuum of care, so linkages and integration between the community and the facility and back to the community for better health outcomes. I think that was the clear message given by Dr. Pavitra Mohan. And it is very simple and easy, even if a worker can be trained, can provide basic newborn care. So I think it will benefit all our audience to take up newborn care as one of their activities in the community, which many of them are already doing. So we have next speaker, and for the next session, Dr. Sanjay Prabhu, sir, you are there. Can you just say hello? Dr. Sanjay Prabhu? Hello? Can we just confirm whether Dr. Sanjay Prabhu is there?
Yes, he is there.
I saw him joined, but in between
Yeah, I'm there.
Yeah, Dr. Sanjay, welcome.
He's there.
So it is my pleasure to welcome Dr. Sanjay Prabhu. He is the in charge of State Center of Excellence in Pediatric Nutrition at Wadia Hospital for Children in Mumbai. And he's also a senior consultant for UNICEF. And he has been a secretary of Maharashtra BPNI, which is the Breast Feeding Promotion Network of India earlier. So he has done special work in training of health workers in breastfeeding and complementary feeding in Maharashtra, Chhattisgarh, Orissa, and many other states. And he's also technical advisory, part of the member of technical advisory group for SAM management in NRC. He's also a national trainer for lactation management. We are very glad to have you, Dr. Sanjay, here. So over to you, Dr. Sanjay. And in this session, Dr. Sanjay is going to present on the family actions or practices for care of newborn at home, particularly taking precautions during COVID. And for special babies who are very low birth weight babies, what should be the special care? And also when it should be an alert for seeking hospital care, because we spoke about home-based care now, but we need to be also alert that when we need to take a facility care or a hospital care. Over to you, Dr. Sanjay. I'm sharing your presentation.
Okay. Thank you, Sridhar.
Presentation is visible?
No.
Starting, sir. Now it is.
Can you just do the
Yeah.
slideshow?
Yeah.
Okay.
Sir, it's not full screen yet. It's the same thing which we encountered before.
Yes, I did it. I did. Give it 2 seconds. Is it now?
Fine, sir. Thank you.
Dr.
Okay.
Sanjay, please go ahead.
Yeah. See, the questions which were raised for my talk were that what are the family actions or practices for care of newborn at home and precautions during COVID. Now, Dr. Mohan has already addressed to you regarding the practices which are to be followed in newborn care at home. And a question also was raised whether ASHA would be the right person. But many a time, though we are trying to achieve 100% institutional deliveries, still we are having around 20-25% deliveries still occurring at home. And these may be only attended by a trained birth attendant. So the family involvement in the care of the newborn has become a necessity, along with ASHA, who may or may not be there at that time. So now what happens in most of the rural households is that the basic care which is required for a newborn has not been conveyed to the household by the health functionary. Now what we do in our lactation management program is that we have antenatal classes which tell the mother about breastfeeding, about how to start, how to hold the child, and all those things are taken care in the second and third trimester, where when she is coming for antenatal checkups. Now, this could also be one part of the talk could also be devoted to care of the newborn after delivery, besides breastfeeding. Now, in these breastfeeding talks, we also involve the other relatives in the family, especially the mother or the mother-in-law. And if the father is available, then he's most welcome, because in our country, the father has a lot of say and the mother-in-law also has a lot of say in what will be happening to the newborn. So they are also involved in the breastfeeding talks that we give. Now, once the child is born, we know that there are certain very basic considerations which have to be taken care of in any child who is born. And though the discharge is supposed to be occurring after 2 days in the hospital, but the practical reality is that in most of the children, the mother gets discharged within 6 to 8 hours. So a lot of things which are supposed to be taken care of are not taken care of before the child lands in his home. And so a few things which we have to keep in mind when the child reaches home is, one is about prevention of hypothermia, that is drying and warming of the child. So when the child is delivered, and by any chance if it's a home delivery, a dry and warm towel should be used for drying the child, and a child should be covered in a warm blanket or multiple layers of clothing if the child is born in winter and in very cold conditions. So this is something which is extremely important. Any newborn who is born at home or who gets discharged from the hospital very early. Prevention of hypoglycemia, the low sugar problem is always going to be there in any newborn, especially when we have a 30% incidence of low birth weight children. So establishment of breastfeeding is the most crucial thing as far as prevention of hypoglycemia is concerned, besides warmth. And for giving warmth, we also talked about kangaroo mother care, but that requires some sort of training for the mother, and it has to be supervised by some person who is well trained. So in a home setting, advising kangaroo mother care to a absolutely new mother would be a slightly tricky situation. But a mother who has been utilizing kangaroo mother care in an SNCU and who gets discharged and the baby is being taken care at home could continue kangaroo mother care at home till the child is reaching around 2 to 2.5 kg. Now, I will be talking about breastfeeding in the further slides. Prophylactic eye care is what is now commonly prescribed. That depends on the state and the institution. Some newborn units use ointment, some use drops. It is a preference of the unit, and this has to be continued to prevent bacterial conjunctivitis. Now, newborn weighing preterm or low birth weight is the most important thing, which I feel Dr. Mohan has already shown you. If the weight gain or weight loss is there in the child, it is not accurately documented. So for that, we have to have a proper weighing scale. If the child is below 2.5 kg, then he is classified as low birth weight. If the child is preterm, then we have to take special care of these babies, and these babies may have to be transferred to the SNCU. Umbilical cord and skin care are other important points. Umbilical cord care, as we know, has now become like that. You just leave the cord dry and tie it with a thread, or you have these cord clamps which are available at a very reasonable cost, and they don't require any special ointment or antiseptic lotions to be applied on the cord. And the skin care is the most important also because of cultural practices which are prevalent in our country, that they give a very early bath, and sometimes they use this chana atta or some other ingredients which are locally available for cleaning the skin, because they feel that the lanugo hair which is there has to be cleaned out. So these are all dangerous things, and they can cause a lot of skin infection and can also cause a lot of sepsis. So we have to be careful in telling them that the bath should be delayed at least for 24 hours. And if the child is preterm or low birth weight, then maybe for 7 days till the child is quite stable. So, and the bath should be used with lukewarm water or warm water depending on the outside temperature, and a gentle soap is what is all that is required, and nothing else is required. Detection of pneumonia and sepsis, we will see in the danger signs, that how will we recognize them. Now in this COVID times, what is being now stressed is personal hygiene and hand washing. Um, the first talk which we heard, and there was a issue about whether the mother should breastfeed during COVID times or not. We will see in the next slide about COVID and breastfeeding. But toilet practices, now that we are, our country as a whole, and some states are now open defecation free, dental hygiene, use of safe water, and cleaning of hands after any making the meals or handling the child has now become a norm, even if the mother is not COVID positive. So this personal hygiene of the mother and hand washing has now become an integral part of the society. And what I would also say is that a daily bath by the mother is what is more important. And before every feed, we need not wash the breast. Only once the mother takes the bath in the morning, that is enough. And we don't recommend cleaning of the breast and the areola before every feed. But hand washing is the most important thing. And can we have the next slide, Dr. Sridhar?
Yeah. Dr. Sanjay, before going to next slide, I just want you to elaborate on what do you mean by prophylactic eye care?
Prophylactic eye care is use of antibiotic ointments or eye drops before development of conjunctivitis.
Mm-hmm. Okay, because in our programs, usually it is not. We have one question from Dr. Bakshi also, that do we need to give
some
antibiotic?
Of the states have now stopped it. Maharashtra is still using it. That's why I put this slide. But
Okay.
it depends on the institution where the child is born and what are they practicing.
Mm-hmm.
But most of the maternity homes in the government sector and the large hospitals are still using prophylactic eye care in Maharashtra.
Thank you, Dr. Sanjay.
Yeah. About breastfeeding,
yeah, please.
What we should know is the golden hour. We know all about the first hour of life, which is the most crucial as far as the baby is concerned. And what is more important is that if the breastfeeding begins within the first 1 hour, we can reduce the neonatal mortality by around 22%, which is a very, very significant amount of time, very significant amount of percent of the neonatal deaths. So this is very important. And if the hospital delivery is there, then we use a method called as breast crawl. But in a home delivery, I would say that after the cord is cut, the baby is handed over to the mother and breastfeeding is established as early as possible. Now, positioning of the baby and attachment on the breast is something which is most important and which many mothers don't know. And even the family members are also not very aware of that. So in the next slide, we'll see what is this positioning. Then we also have to make the family aware of the importance of colostrum. In our earlier times, we used to discard the colostrum culturally, but the colostrum is a very high vitamin A content, very high immunoglobulin, and it is, I would say, it is the first vaccine for the baby, and it helps in passage of meconium. Now, early days, when that is the first few days, initially the teaching was that the baby should be demand fed, but we have now progressed to what is called as cue-based feeding. We will see what this cue-based feeding is. And what is most important and what is often neglected is weight loss. Now, these babies may be weighed at birth, but nobody takes the weight at 3 or 7 days and 14 days as per the ASHA program. I doubt if the weights are done again. And in many of the hospitals before discharge, the baby is never weighed. So if the weight loss is significant and more than 10%, or if it is more than 5% in a day, these babies are at risk of getting malnourished very early in life. And the other thing which we have to rule out is infection. So these are the two very crucial things. And recognition of jaundice, because jaundice is directly related to breastfeeding. The better the breastfeeding, the less will be the jaundice. But early recognition of jaundice is extremely important for the neonatal mortality and morbidity. Now, breastfeeding conditions and problems are also faced by a lot of mothers. There is no time to talk about each one of them, but the most common problem which the mothers face is sore nipples or cracked nipples or engorgement. Now, these are all related to improper attachment on the breast, and these can be solved by a trained person who can help the mother to latch on, for the baby to latch on the mother's breast. And one other technique which mothers are not aware is how to express milk if the breast gets engorged. So this is something which has to be taught, and which has to be taught antenatally and also reinforced postnatally, that how should you express the milk. Can I have the next slide?
Visible, sir?
Yeah. So this is what
Yes.
we are talking about, attachment on the breast. We have two figures here, what is good attachment and what is poor attachment. I will talk about the good attachment first. You can see the mouth is wide open, the chin is touching the breast, and the lower part of the areola, as much as the areola you can take into the mouth is what is desired, but the lower part should go in more, and because the baby is going to strip the milk of the breast. And the other thing is the lower lip is everted outside. So these are for the four things which have to be remembered when you should have a good attachment. Then the next thing is how to position the baby as far as the mother is concerned. The baby has to be turned towards the mother, and the baby's abdomen and the mother's abdomen should be touching each other. The baby should be well supported from the back in a straight line. The head and the shoulder should be well supported, and the mother should be sitting very comfortably either on the ground, or if she has a chair with an incline, the back should be inclined. So the mother should not be bending forward to feed. And when she feeds the baby, she should be touching the upper lip of the baby. And when the upper lip is, the nipple touches the upper lip, the baby opens the mouth wide, and the baby can then start breastfeeding. Now, two more important things which we always recommend is that hold the breast as a C shape. In our country, we have this what we call as a kainchi grip, like a scissor we hold. The scissoring is not good for feeding. It stops the flow of milk, and the breast should be held in a C shape. And while the mother is breastfeeding, the mother should be continuously also talking with the child. So the sensory impulses are provided to the child, to this developing brain. And the more the mother interacts with the child, the brain development of the child is better. Can we have the next slide? This is something which all of you have to take home, that the frequency of breastfeeding is directly proportional to the blood sugar and inversely proportional to the serum bilirubin. Now, the more you breastfeed, you are going to have a normal sugar, and the bilirubin is going to go down. So the cause of hypoglycemia in most of our babies is improper feeding. And similarly, we have a problem about neonatal jaundice, which is also directly related to improper breastfeeding practices. So this is something which I think everybody should take home. Next. So we used to talk about demand feeding earlier, but now that has gone to what we call as cue-based feeding. It is at least 10 times in the first 24 hours for the first 7 to 15 days, or till lactation is established. It's a proactive feeding, and you have to recognize what are called as early feeding cues. Wake up the baby when it shows feeding cues, and feed them at least 10 times in the first 24 hours. In a primey, it may take around 4 to 5 days for the lactation to establish. But in a multi, the lactation may be established by day 2 also. So what are these early feeding cues? They are sucking movements, sucking sounds, hand to mouth movements, rapid eye movements, soft cooing or sighing sounds, restlessness. And please remember that crying is a very late feeding cue and may interfere with effective breastfeeding. So you don't wait till the baby starts crying to put the baby on the breast. Can I have the next slide? So this year we are concentrating on COVID and the newborn. But what is very, very heartening to note is the essential practices are going to remain the same. Now, breastfeeding and skin-to-skin contact is still the norm even during COVID times. Now, we at Wadia, we have a sister institute, which is a COVID hospital, COVID maternity hospital, and we have delivered scores of mothers who were COVID positive. And the good thing is that the transmission of the virus from the mother to the baby is negligible. It has not been demonstrated in accepting for case reports, intrauterine transmission or transmission through breast milk has not been still confirmed. And the transmission of the virus from the mother to the child is also extremely low. So, I mean, I would say in our situation in our hospital, it was around 3%. So, 97 mothers who were COVID positive didn't transmit the virus to the baby. And even if they transmit, they don't require any specific treatment. So, we, as per WHO and UNICEF,
Hello. We lost you, sir. Hello. Hello.
skin to skin contact whenever the baby is breastfeeding. Kangaroo mother care also is encouraged, and mother is asked to use a medical mask and hand wash or sanitize her hands before feeding. Now, if other members of the family are affected, baby to be handled only by the mother, and the other members of the family are not allowed into the room where the baby and the mother are staying. So this is something which we are encouraging now, and there is no problem about breastfeeding, and breastfeeding has been going on in these children very successfully. And we have not, now we have our first cases came in June, and now we are in November, and none of these babies have come back to us with COVID positivity who are successfully breastfed. So breastfeeding has not created any COVID transfer as far as newborn babies are concerned. I think other centers also will be sharing the same experience. Can I have the next slide?
So sorry to intervene, but we have around 2 to 3 minutes more to conclude this session.
Yeah, I think this is the last slide.
Special care for low birth weight babies is provide extra warmth by wrapping baby in clean sheet, clean blanket. Now, most important for low birth weight babies is head is to be covered to prevent heat loss, and delay bath for 7 days, especially for very low birth weight babies. Now, keep baby close to mother's abdomen and chest, and if you have a facility or this mother has come from an SNCU where she knows about kangaroo mother care, or your ASHA is very well trained in kangaroo mother care, the same can be encouraged at home. But this becomes a little tricky. I mean, it all depends on the expertise of the person who is going to take care of the mother. Now, these babies have to be fed more frequently and only breast milk, and all babies who are less than 1.8 kg have to be referred for admission to a SNCU, and watch for danger signs more closely. And most important for these babies is watch for weight loss. Now, these babies are very prone for extraordinary weight loss, and these are going to be very sick in no time. So this weighing is something which I would like to stress is an extremely important part of home-based newborn care, whoever is practicing and whoever is going to take care of the newborn at home. So this visits at 1, 3, 7 and 14 are very crucial. And if the baby is still losing weight at 3rd day and continues to lose weight at 7 days, you are in trouble. And by 7 days, the weight loss has to stop and the weight gain should have started. And by 14 days, the baby has to come back to the birth weight. Can I have the last slide? So what are these danger signs that we have to pick up when the baby is at home and is being cared by an ASHA worker, or maybe the family is helping in care? If the baby is limp and not moving, this is a danger sign. Feeding is less or feeding is stopped completely, it's a danger sign. It is crying very less, or it has a very irritable and inconsolable cry, or weak or no cry. All these are danger signs. A distended abdomen or a baby vomiting repeatedly, baby feels cold to touch, and temperature, if you have the thermometer available more than 99 degrees, any chest indrawing is a danger sign. Pus on the umbilicus, eyes which are swollen with pus, weight loss more than 10% of the birth weight, yellow skins and eyes, this will depict jaundice. And if the skin has become yellow, then it will be deepened jaundice. And pustules on the skin. So these are all some very basic danger signs which are to be recognized by the ASHA worker, or maybe the family if the ASHA worker is not available, and the family has to get in touch with the doctor, nearest doctor available, which may be a PHC or a hospital if it is in a bigger place. Thank you very much.
Thank you, Dr. Sanjay. Thank you so much. I think these are, while we are giving home-based newborn care, it is also important to diagnose or detect these danger signs early and get a right referral at right facility and get the right treatment started immediately so that we can save many newborns. There are not much questions in the chat box. We have a comment from Anita, and of course, the relevant comment that in comfortable situations, this all works, but the situation of women in India, especially in marginalized and migrant population, the issues are more. But again, what Dr. Pavitra Mohan said, that it is a teamwork. If there are the volunteers, the frontline workers, and the physician at primary health care, if they work as a team, I think we can reach these services to even the remotest places of the country. Only one question, Dr. Sanjay, you told about weight loss more than 10% of birth weight as one of the danger sign. The question is how much weight loss per day?
See, anything more than 5% per day is dangerous. Usually the term baby loses around 7 to 8% of weight by around the third day of life. And a preterm baby will lose more, means maybe 1 or 2% more. So any day, if there is a more than 5% weight loss, it is dangerous. And cumulative loss more than 10% means these babies have to be monitored very closely. And if the weight loss is more than 12.5%, these babies have to be admitted because they have a unique thing which we call as their sodium goes up in the body. We have what we call as an hypernatremic dehydration. So these babies have to be managed in a hospital setting.
Thank you, Dr. Sanjay. I think we are on time for your session, but overall we are exceeding 10 minutes. So we will move on to the next session. So we have a senior officials from the state of Chhattisgarh to share their experience on the Mitanin program, which is called as ASHA program in the other states in the entire country. Can I just confirm with Dr. Amar Singh Thakur and Dr. Samir Garg is there? If they can say just hello.
Yeah. Yes, I'm there. Yeah.
Yeah, Dr. Samir is there. Dr. Amar Singh?
Yeah.
Thank you, sir. So let me introduce the panel for this next session. We have Dr. Amar Singh Thakur. He is a pediatrician and has worked for more than 16 years in one of the district hospitals in Bilaspur in state of Chhattisgarh. He was the first newborn unit way back in 1998 was established in his hospital with his efforts. And he also got the first baby-friendly hospital recognized in the same year for the state of Chhattisgarh. Later, he has worked in various capacities as a civil surgeon, as a chief medical and health officer, as a joint director. And since 2015, he has taken the responsibility of the child health immunization and the adolescent program in the state of Chhattisgarh at the Directorate of Health and Family Welfare Services. So recently, he is also promoted as the director of State Institute of Health and Family Welfare. A warm welcome to you, sir, for this webinar.
Thank you, Sridhar.
We have Dr. Samir Garg. Dr. Samir Garg is Executive Director of State Health Resource Center for State of Chhattisgarh. He has been part of the team that pioneered the Mitanin program, which later was upscaled as home-based newborn care program in the entire country, and also many other community-based initiatives in the state of Chhattisgarh since 2002 onwards. So he has a rich experience of 24 years from the field. He is an institution himself in the state of Chhattisgarh, and the state is benefiting from his experience in the field. He has also a PhD in his credit in the health systems and management, and primary health care is his primary area of interest. Welcome, Dr. Samir Garg. So we have a joint presentation from Dr. Amar Singh and Dr. Samir Garg. So we have first initial presentation by Dr. Amar Singh on how they are implementing the care of newborns at home. We heard from Dr. Pavitra Mohan and Dr. Sanjay Prabhu the importance of home-based newborn care and how a frontline worker can make the difference. And here we have a state which has implemented it for the first time in this country, and we request the state team to present their observations or their work in the state of Chhattisgarh. Over to you, Dr. Amar Singh Thakur. I'm just sharing the presentation.
Thank you, Dr. Sridhar, and good evening to every participant. As you all know that Chhattisgarh state was formed in 2000, and at that time the health scenario in Chhattisgarh was not up to the mark, and it was of our, like, all those who were at that time in the ministry, in the bureaucracy, and also in the departments, they worked very hard and they could get what was needed for the state. And that started with the beginning of the Mitanin program from 2001 and 2. So with this background, I will take you to the development of the newborn care in the state of Chhattisgarh, where we were we had this figure, you can see it, that in 2005, we had this infant mortality rate that was about 63. And whereas the infant mortality rate of the India was at that time 58. And gradually we were able to narrow this down. And we almost brought it up to 33 in the 2017 and 38 in the 2017, when for India it was 33. So that was the difference of 5. But in 2018, we had a more difference, and this could have been due to many reasons. But similarly, in similar way, we also had like neonatal mortality rate reduction from 45 and 37 to the 26 and 24. So this shows that we have been struggling. We have been struggling to reduce the neonatal mortality rate and infant mortality rate, and we were doing for all sorts of practices to reduce these things. And one of the very important thing was home-based newborn care. Home-based newborn care, I will say that home-based newborn care, when we started in 2000, and then gradually when we established having this network of the Mitanins in the Chhattisgarh, and that was the first of its kind in whole of the nation, and that was later sort of accepted in the national health sphere, where they came out with the ASHA program. So that was the one of the important innovations. As you all know that आविष्कार ही आवश्यकता की जननी है. जब हमारे पास इस बात की आवश्यकता थी कि हमें किसी भी तरह से neonatal mortality को, infant mortality को कम करना है, and we had very poor resources. We were the state with have-not situation, where the other states were of the have situation. So to make all these things happen, our top leadership and the bureaucrats and all the health team, they tried to make the things happen. So next slide, please. Sridhar, next slide, please.
Yes, sir. I have moved it. Is it visible now?
Yeah, it's visible. Yeah, it's visible. So, this is the history of the Mitanin program and the care of the newborn at home in Chhattisgarh. So, Mitanin program was started by government of Chhattisgarh in 2002, and it was one of the India's largest community health volunteer program. And Mitanin in Chhattisgarh means it is a local word, and that means a friend, Mitan, and when it is a female, then it is a Mitanin. So it is a female friend. And similarly, what is the Swasth Mitanin? So it is the friend of the village for health care needs. So these two concepts, they made the thing click. Focus brought on more community-based services, not only for the newborn, not only for the pregnant woman, but all the health needs were identified, all the health needs were addressed gradually and slowly. So government recognized the importance of active civil society partnership, and we came out with the State Advisory Committee of Civil Society Organization. We also set up State Health Resource Center. That was the greatest boost for the Chhattisgarh state. When we started this State Health Resource Center, when the Raman sir was here, and gradually people came and they all contributed for the setting up of the this SHRC, and that strengthened the community process in Chhattisgarh. Mitanin program was upscaled, a RASA program in the country, as I said earlier, and Mitanin provided home-based newborn care many years before the national level launched the HBNC program in 2011. So, Hamar Swasth, Hamar Adhikar, that was the sort of logo that healthcare services is our right. And similarly, the Hamar Swasth, Hamar Hath, that is our health in our hands. So this Mitanin program not only empowered the female of the Chhattisgarh at the downmost level, but it also gave them the right to the people. What the Pavitra Mohan sir was saying, what the Suresh Prabhu and other speakers previous to me were saying, that we need to take it to the home. When you take the health program in the home and give them the right, that this is your right, you have to get it, and you have to in situation you can ask for it at any time. That is the ideal situation when we need to have those things in our society, and in our society means the society who is most marginalized, most underserved, and they are the rural, mostly people where the facilities are low. Then the Mitanin program's structure, if you can see how it has been structured in our state. So there is a apex body at the SHRC, like as I said, SHRC, State Health Resource Center, and that coordinate with the MD, LHM at the state level. And then there are district coordinators that coordinate with the chief medical and health officers. And there are the block coordinators, they do coordinate with the block medical officers. And then there are Mitanin trainers who facilitates, who train the Mitanins, and they are there for every 20 Mitanins, there is one Mitanin trainer. And for and every Mitanin is catering the population, local population, of their own population, of the 300 population in a village. So we do have sort of Mitanin numbers in the state is 72,048. At rural area, these are 68,277, and at urban area, 3,771. So this is the preliminary introduction of our HBNC care. Now I request Dr. Samir to take it forward.
Please, Dr. Samir. I think 72,000 Mitanins. I think this is a massive program, and Dr. Samir is heading it. Let us listen from him. Visibility of these Mitanins.
Thank you, Dr.
Over to you, Dr. Samir.
Thank you, Dr. Thakur, for introducing the Mitanin program. Thanks to Sphere India and to UNICEF for giving us the opportunity to share our work with this audience. Mitanin program, as Dr. Thakur was saying, it was a vehicle of promoting community participation. So one issue when it was started was that we did not have enough health workers, we did not have enough infrastructure or human resources. So reaching the people was a problem for Chhattisgarh. It was a very backward and highly, very poor state in that when it was formed in year 2000. But the concept for Mitanin was also that community participation is absolutely necessary if good health is to be achieved for the population. And unless people themselves are part of that process, so health is not something which the government can hand over to the people. It is something that people and government, they have to work together to co-produce. So with that objective, it was started, and the role roles that the Mitanin has, there are 3 roles that we see for the Mitanin. One is of a link person. That is the most commonly known role of the Mitanin, that she will identify the various people who need healthcare, and then she will link them with the formal healthcare services of the government, and so as a link person. But the other 2 roles are also equally important. That role is, one is of being a health educator and a local health provider. So for the simpler healthcare needs, she also provides some healthcare, and she's the most available or most important health educator available at the community level. So the idea was that somebody from within the community should come forward and learn about health, and then to motivate and mobilize the rest of the community around them for better health in a holistic manner. So the third role for Mitanins was of as an activist. And the word continued into the ASHA also, where the ASHA is also is an accredited social health activist. So the activism was the third objective of Mitanin, where she was supposed to take care of not just make people aware about their better health practices, but also make them aware about and mobilize them about and organize them around their rights. That healthcare services is a right. It is something that every citizen should get, and also that health is also depends upon many social determinants like good water and food security, gender equality. So a lot of those components are also very important for health. So to mobilize communities around these rights, that was the third objective. So with these objectives, the Mitanin program, these 3 roles, it was started and it was scaled up very fast in its initial years. So regarding newborn care, one of the first things that Mitanin started, it was in 2002, their first training itself was called Hamare Bacche Unki Sehat, our children and their health. So, and the first thing that was taught to them was about breastfeeding, and much of the improvement that Chhattisgarh achieved from year 2001 to 2006. So the Chhattisgarh, so the graph that Dr. Amar Singh showed, so that started from 2005, but he was trying to say that before 2005, the decline was much faster. In Chhattisgarh, when the low-hanging fruit or the more doable of the changes, they were achieved in the state, and the breastfeeding promotion was the first thing that Mitanins took up. Early initiation of breastfeeding, colostrum feeding, those were the indicators which registered a major change. If you look at the National Family Health Survey, the second National Family Health Survey 1998, and you compare it with the 2005-6, the NFHS 3, then there was a big change in terms of newborn indicators, especially related to breastfeeding, then related to immunization. So those things changed very fast in those years. Which we guess that contributed to improvements in neonatal and infant in reducing these mortalities. So then breastfeeding was one component of newborn care that Mitanin started working early on, and where they got the early success also. So then rest of the components of newborn care were thought to be too technical, that we were not very sure whether Mitanins will be able to learn those technicalities, how much knowledge can they gain, because Chhattisgarh had very poor literacy rates, and most of the Mitanins, their average education was not very high compared to other states. So that was a big concern, how to whether it is a feasible idea to impart them more and more skills, and to expect them to carry out more technical aspects of newborn care. So but in 2007-8, a plunge was taken in collaboration with UNICEF, where SHRC, UNICEF and the Directorate of Health, so they jointly thought that let us train Mitanins on newborn care. So a module was designed by adapting, so it was focused on newborn survival, and so in that training, so they got the basics of newborn care in 2008, and that was the 10th round of Mitanin training. These rounds of training are how many modules of training they have been given. So 10th means they had already received 9 trainings before that. So 9 modules of training they had already received when they reached newborn care. So it was not easy journey for them. So it was after they had gained experience of 5-6 years of working as Mitanins, as community health workers. So they were working on, for example, on oral rehydration for bigger children, and they were working on malaria. So they were working on many other public health issues, but in newborn care, they had attempted only the breastfeeding part. So in 2008, when they were trained on newborn care, so then they learned about where they need to intervene. So then the concept of these visits on first, 4th, 7th, 15th day. So those visits, that concept came in, that those frequent visits to newborns are necessary. Before that, I can say that it was not seen to be, it was not part of Mitanin's work or practice to go so frequently to houses of newborns. So they were involved in antenatal care to an extent. And those days, the institutional delivery rate in Chhattisgarh used to be very low till 2008. Then what do they do? What did they learn in the trainings? So the things that they learned in the trainings were, first, there were 3-4 main things. One was the breastfeeding, of course. So they built on the earlier knowledge they had about delivering messages or behavioral change around breastfeeding. So then there was another component which they worked on many years till then, that was around maternal nutrition. So when the mothers, so in Chhattisgarh, there used to be a strange custom that in amongst a lot of communities, that to keep the mother hungry for 2, 3, sometimes 4 days, and not to give them any food after childbirth. So which was very, very harmful practice. So the Mitanins worked on that, and they achieved a fair degree of success in changing that practice. Still in many locations, people refuse to give them what they call wet food, or like rice and dal, which is like the staple food here. Instead of that, they agreed to give them roti or relatively dry stuff, which according to their customs was less of a risk. Otherwise, they used to always feel that if the mother eats, then it can harm the child. So they used to keep the mother hungry. And that used to create problems for the breastfeeding part also with the anxious mother. So what were the things other than breastfeeding? So they looked at hand washing. That was the second part, that promoting hand washing, that any newborn has to be touched or handled after washing hands. So which they promoted. Then the third part was about keeping the babies warm. So these were 3 simple things around which a lot of their work was centered around. So these ideas, these practices, practice of going to their homes and advising. So that took shape from 2008 onwards. So, and then there was the challenges were manifold. So the other purpose of their home visit of a Mitanin is that she is able to identify the danger signs, that the list of danger signs which earlier Dr. Prabhu showed us. So similar list was taught to Mitanins, but it was not easy getting them into a practice of checking all those, whenever they visited a newborn, that you check all these things, you check if the chest is indrawing, you check all those other signs. So it took us a lot of effort for getting the Mitanins into the role of looking for danger signs. And for that, you can see on this slide that so many rounds of training were done, where a refresher was provided to Mitanins to learn those things well. And so when we are dealing with community health workers, and so the
slight change is required, I think.
Yeah. Yes, Dr. Sridhar. Yeah, the next slide. So then, so multiple rounds of training were needed for Mitanins to learn these aspects well, and to ensure that so many Mitanins are there, 72,000. And when we teach them through a cascade method, through a TOT kind of approach, so then one has to ensure that whether the right skills are reaching the last level. So what has helped us, apart from the classroom training for Mitanins, is the Mitanin trainers. So their supervisors are called trainers because they're not only there to supervise the Mitanins as their, but more of a concept of a supportive supervision is there, where they actually go with them into the houses and help them. So every Mitanin gets at least one visit from the Mitanin trainer. That's why we call them trainers also, and they provide them the hand-holding support and help them in gaining the requisite skill and confidence to look at the newborns. Then a number of picture books were designed for Mitanins, so locally, where or with help of other partners like UNICEF, so that they can they have easy ways of communicating. So this the logistic and supply, so that has been one of the weaker areas in the program, where a lot of the counseling part, visiting part, so we have been able to achieve good coverage rates. But here you can see around half the Mitanins have these kits, and these kits were initially given to, this is the current number. Earlier, most of the Mitanins in 2008 received the kits, but a lot of the replenishment became an issue after later, and so many of the village health committees, they help them in buying the weighing scales or thermometers now, and UNICEF helped in some areas, some tribal areas. So that's how 30,000 Mitanins have these kits. But apart from having the kits, the other challenge is putting it into their practice, how Mitanins, whenever they go, they carry these things with them, and they should use these items for the drug supplies to Mitanins. Those have improved over the years, and then when later the government of India introduced amoxicillin for Mitanins, so that also they started getting from 2017 onwards. So now they have experience of 4 years of handling amoxicillin at the local level also. Next slide, please.
Excuse me, sir. We've got a couple more minutes to wind up the session. Thank you.
Yeah, thank you, Thomas.
Next slide.
So, yeah, is it visible?
Yeah. So this shows some of the things that they carry out. Like I was talking about keeping the baby warm. So they have a version of Kangaroo Mother Care, a locally adapted version. Then they have a baby wrapping skill. So which a lot of them have the skill as well as the practice of carrying it out in the field. So now a lot of them identify the danger signs. And in fact, now usually we don't worry about underdiagnosis. We usually worry about overdiagnosis, that they are identifying more children than we expect to be having sickness. Demonstration of hand washing you can see, and counseling of mothers and the rest of the family members. Next.
Thank you, Dr. Samir. I think I request Dr. Amar Singh to finally conclude on this Mitanin program in Chhattisgarh, telling us what is the success and challenges they are facing in the state in terms of implementation of this program. Over to you, Dr. Amar Singh.
Yeah. So now you can see that the what were the successes of the Mitanin program, like knowledge, skill, practice of Mitanin and care of newborn at home. They were assessed by UNICEF in 2016 and 17. And these are the key findings. And you can very well see that we started this program in 2001. And by the time 2016 and 17, the Mitanins, they were trained. Initially, we had Mitanin who were very difficult to be trained at the initial stage, but later on, all those Mitanin only, they could be trained. 89% of Mitanin visited 7 or more times within 42 days of birth. And 90.5% Mitanin had adequate knowledge of key newborn care messages. And 97.3 Mitanins, they knew about skin-to-skin contact care and an observation. 94% could demonstrate the right method. And 98.8% of the Mitanins were aware about feeding up colostrum to newborn. And 92% Mitanin could demonstrate baby wrapping skill adequately, and 98% of Mitanin gave advice on hand wash to mother before touching to newborn. So these are the successes that we could achieve through this Mitanin program. Next, please. Next slide, please.
Visible, sir?
No, it has not changed. Yeah, this one. So, so achievement over the last 5 years from 2015 to 16 to 1920. So total number of newborn visited at home in HBNC is 19,54,369. And and they could identify 1,89,357 low birth weight and preterm babies and reported out of those visited, and 1,86,301 sick newborn were referred, and follow-up visit done for 1,29,017 newborns, and 34,112 essential discharge babies, they were followed up at home. So HbA1c services provided by, this is the evidence that we provided through Mitanin, this HbA1c services. And I will tell you that even at the time of COVID, when everything was stopped in Chhattisgarh, we never stopped the immunization, and we did not stop all the functioning of the Mitanins and even the ANM and other ones. So during we were the first to come out with the guidelines that was also being like appreciated by the central government. So during COVID-19 pandemic, HbA1c services, they remain uninterrupted. Mitanins continued to provide home-based newborn services, and 1,84,003 newborn, they were visited. 17,820 low birth weight and preterm baby, they were identified and visited, and 14,494 sick newborn were referred. And despite of the HbA1c being a new program, it was implemented, and visit for 2 lakhs and 14,402 young children, they were done up to the age of 15 months, and 14,911 sick children, and 2,03,306 severe underweight children, they were identified. So we even at the time of the COVID, we continued our services through the Mitanin, our HbA1c and HbA1c program. HbA1c, we have mainly focused in the aspirational districts only, because the training were completed in these districts only. So these 10 districts, they were like conducting the HbA1c services, and rest of the districts were having HbA1c services. Next, please. Next slide, please.
Yes, sir, it's coming.
Yeah. So, but then we are having a lot of challenges also, not only for the HbA1c, but many of the area need to be taken care of with like follow up of essential discharge baby at community, need community engagement. Still further community engagement is needed. Most of the time what happens when this baby, they are discharged, so they may visit facility visit, they will do 1 or 2 visit and then they will drop. So many a times we are struggling for that. All the facility, it should be completed, and then through the HbA1c program also we will be able to address this issue. And very high prevalence of low birth weight, nearly 10%. So need to improve maternal nutrition. So this is another aspect in Chhattisgarh where the nutrition is very important to be taken care of. Of course, we have started Mukhyamantri Suposhan Yojana also in Chhattisgarh, and we hope that we will be able to reduce the malnutrition in mother and in children and also in adolescents. And then exclusive breastfeeding. And for this, we also started Anganwadi centers. Where the rest of the country did not open the Anganwadi, but Chhattisgarh is the state who opened the Anganwadi center for 2 services only. One is for immunization and other is for the nutrition. And then third is the exclusive breastfeeding. We do have like 77% of in the this one, and need community demand and support. So this we need to through IEC and other activity, we have to increase it. And then implementation of infant milk substitute feeding bottles and Infant Food Regulation Act. So need awareness. So this is not rampant in any way in Chhattisgarh also, but we need to make them aware of this act also. And then procurement of HbA1c kit. This is our problem, and we are like doing it for last 2-3 years, but have not been able to get it for say about in some of the districts. We do have procurement in through the district collectors, but central procurement has not been like become reality till now. Next, please.
That was the last slide, son.
Yeah. So I thank you. I thank you to the UNICEF. I thank you to the Sphere India, and I thank you to Dr. Samir sir also and Sridhar ji that we were given this opportunity to present our achievement as well as our challenges. And I hope that with all these stakeholders and the persons who are there to help us and our own health team, we will be able to come in the first row of the achievers in the nation. Thank you very much.
Thank you, Dr. Amar Singh. Thank you so much, and Dr. Samir. So we have heard from the experts. We saw the need of continuum of care from Dr. Pavitra Mohan, and what are the components of home-based care and the danger signs from Dr. Suresh Prabhu. And here we have an example from the state of Chhattisgarh where they have shown that it can be implemented. So when we listen from the experts, now we have Sunita ji, who is a Mitanin in the state of Chhattisgarh. So she is here with us to share her experience quickly for next 2-3 minutes, how she is providing this home-based newborn care. Sunita ji hai, Dr. Samir?
Yeah, she'll just join.
Yeah. सुनीता जी बताइए आप कैसे होम बेस्ड न्यूबॉर्न केयर कर रहे हैं और आप कैसा अनुभव है आपका? सुनीता जी?
I'm requesting Sunita ji to unmute herself. आपके पास एक पॉपअप आ रहा होगा स्क्रीन पे, आप उसको प्लस ओके कर दीजिए बस. She's not able to unmute herself.
I'll just help her.
So if it is taking more time, Dr. Samir, can we proceed?
Maybe we can have it in the later part in the Q&A.
Yeah, or can she
can
use your
have it.
laptop, Dr. Samir? Yeah, we'll take it later, Thomas.
Okay,
So
sir.
we are going for the last session of the day. Yeah. So we have this last session on urban challenges for newborn care. So Dr. Neena Ghosh and Dr. Subhashish Roy are joining us as panelists. Can I just confirm their presence? Can they say hello?
Yes, I'm here. Hello.
Yeah, Dr. Neena is here. Dr. Subhashish Roy?
I am here.
Yeah,
Hello.
thank you. So let me introduce the panelist for the last session. Dr. Neena Ghosh is a pediatrician at Ramakrishna Seva Pratishthan, Kolkata. She is involved in care of children and newborns, infant and young child nutrition. She is a national trainer for BPNI's IYCF counseling and lactation management course. She has a keen interest in advocacy for good nutrition for everyone. Welcome you, madam, for this webinar. And sorry for keeping you waiting for half an hour. We are delayed by half an hour. And we have Dr. Subhashish Roy, who is a pediatrician, consultant pediatrician in Columbia Asia Hospital, and also the immediate past secretary of West Bengal chapter of pediatric pulmonology for duration from 2012 to 2018. He is a member of executive body of National Respiratory Chapter. We are very glad to have Dr. Roy here. Thank you for joining us. So we heard all this presentation of home-based newborn care, but it was more focused from rural perspective. So when we say about health, not only newborn care, we say we have that assumption that everything is good in urban because we have a good urban infrastructure, and we have a rich people comparatively to rural areas in urban. But do we have challenges for newborn care in urban? So that perspective we will try to understand from Dr. Nina, and we have some suggestions and solutions for those challenges from Dr. Roy coming up after Dr. Nina. So over to you, Dr. Nina. I'm sharing the presentation for you.
Thank you, Dr. Sridhar, and good evening to everyone. So caring, we'll wait for the slide to come, but I'm starting to speak.
It's there, Dr. Nina.
Okay. So caring for newborn babies in urban India, and especially those in socio-economically disadvantaged situation, it's challenging in many ways. Even though there has been a very fast urban population growth, and the number of people who are now living in cities and towns is much more than it was even 1 decade ago. The municipal corporations, governments, and even healthcare providers, they have not been able to keep up with this need to build essential facilities for the people living in the cities. And cities have certain unique problems. There are certain city dwellers have certain problems which are not faced in the urban areas. So because of this, life in cities, it may not be all that safe, or it may not be all that healthy for everybody. So today I'm going to point out some of these problems that city dwellers face. And I'm also going to point out some of the problems that we face when we are seeing these newborn babies. So according to the 2011 census, India had a total population of 1.21 billion people in 2011. And of this, more than 377 million live in cities and towns. This number is supposed to become 590 million by the year 2030. And India has more than 7,000 cities, but of these, 53 cities have a population more than 1 million. And there are mega cities in which the population is more than 10 million. And so you can imagine this kind of urbanization is going to come with lots of challenges. And these mega cities are Mumbai, Kolkata, and Delhi. Can I have the next slide, please?
It's visible.
So this kind of urbanization, there are difficulties for the citizens as well as for the governments and healthcare providers. And thousands of people are migrating from cities, from villages and towns into bigger cities. And because of this migration, there is an increase in the amount of poverty. The concentration of poverty is very high. And these people who are migrating, mostly they work in an unorganized sector. So there is no wage system for them. It is not as if they get a wage at the end of the month. They probably get paid on a daily basis. Ultimately, they are poor. They ultimately live in slums. And slums, again, have their own unique problems. We'll go into that in a minute. We find that almost 14% of people who are living in urban slums, they live below the poverty line, which means the poverty line at that time, it was supposed to be 1,000 rupees. That means that every individual gets less than 1,000 rupees every month for all his needs. If he has less than that, then he's at a below poverty line level. And almost 14% of people are living like that. And even if the person is a middle class urban dweller who's not that poor, maybe he has a monthly wage, maybe he is more educated, but even then there are certain problems he faces. He may not be able to afford good enough housing, so there are issues of overcrowding. Many of them, they have come from other parts of rural India, so their families are small. They don't have elders in the family who can help with childcare. Often both partners have to go to work. And so childcare, caring for the newborn, breastfeeding, all these things are suffering as a result. And at the same time, these people don't have access to government level treatment which they are satisfied with. So they have to pay for even very basic healthcare, and this expense is it's expensive for them. This is a very high out-of-pocket expense for them. So these are all unique situations which people who are living in cities they face. Can we have the next slide? So, but at the same time, the picture is not all that bleak. There has been a steady fall in the neonatal mortality rate in our country over the last 10 years. This improvement in neonatal mortality rate is more in the urban areas compared to rural areas. But it's been found that the early neonatal deaths have not been affected. The death, even now, 75% of neonatal deaths are occurring in the first 1 week of life. And this number has not changed that much, but the overall neonatal mortality rate is less in the urban areas. Even then, urban neonatal mortality rate varies from one state to another depending upon many factors, and institutional deliveries, early breastfeeding rates, vaccinations, these are all factors which determine the health of the newborn baby, and finally the neonatal mortality rate. Low birth weight is a common problem in all states. Again, the rates vary, but the rates are still very high. The rates vary between 19% to 32% from one state to another. Can I have the next slide?
It's there.
So it's a common, yes, it's a common belief that if you live in a city, then of course you are better off. Okay, so if you live in a city and you have fallen ill, then of course you're better off because you have access to healthcare. You can get any kind of treatment that is required, and to a large extent that is true. If you live in the city, there is certainly all kinds of healthcare are more accessible, and especially in mega cities, because mega cities like Kolkata, Bombay, or Delhi, they have got experience of dealing with their urban healthcare problems. So they do have a primary, secondary, or tertiary level facilities, and these kind of facilities are provided by many agencies. State governments provide them, central governments can provide it. There are municipal facilities, and of course there's the private sector. Private sector, not only allopathic, but also Ayurvedic and Ayush or other Ayush traditions, they are also providing healthcare. And these kind of choices are available for all, for the city dwellers, and they choose according to what they can afford. So there is a wide range of healthcare facilities which are available. There are choices for people depending upon whether they can afford to go either to a solo practitioner or to a multi-specialty hospital. So these are the things that are available for city dwellers. But these are facilities which are more commonly available in bigger cities and in mega cities. And the smaller towns, the healthcare systems are not going to give you that many options. The healthcare services are fragmented. The government bodies are not that prepared. So often if there is a problem which requires tertiary level care in a smaller town, then those patients need to get referred to another big city or another bigger hospital. Next slide, please. So now we can see that even though there are some facilities available, but there are problems also, and city life may not be always healthy for everybody. There are some challenges that city dwellers are facing, and because these challenges are happening, the newborn who's living in that community is becoming vulnerable. Okay, so what are these challenges? Inequalities. So we've all seen in our cities, wherever we live, we work, we've seen that there are places in which there's extreme poverty, and just beside that, there is great wealth. So there are some people who can afford world-class treatment even for the smallest of problems. And there are still, at the same time, we know of people who have had to forego very essential treatment or even life-saving treatment because of multiple reasons, and one of them being that they can't afford it, but there are also other multiple reasons like accessibilities. Environmental challenges. So we just said that many of these people who live in urban slums, they live in a very unhealthy environment. Their homes are made of poor material. They live in places which are in dangerous places. So say, for example, near a garbage dump or near a water body or even near a railway track. We've all seen that. And this is how they need to, these are the places where they need to build their homes. These are the places where they live. And these situations, these places that they have to live in, they are more infections, transmission of infections, because their homes are small, there is no ventilation, there's overcrowding. So these are all the environmental challenges that urban families and urban communities face. And as far as availability and quality of healthcare is concerned, even though we know that there is more availability of healthcare, the main problem here is that there is no protocol for treating these newborns. There is no, once a newborn is identified by a healthcare worker or by a doctor to be sick, there is no system or there's no referral system whereby a person can be told, you should go to this hospital where you will get the treatment that is required. There's no linking, in the sense that suppose I've seen a newborn baby who requires some treatment, there is no system of linkage whereby I can contact that healthcare center or that hospital, and I can tell them that I'm sending this baby needs immediate care. Everything is the responsibility of the family. They have to take the baby themselves. There's no question of any transportation service which is available. So even if a baby needs very specialized transport, that it's not going to be available. Even if they have to take the baby in a taxi, they have to pay for it themselves. It doesn't matter how poor they are. They have to, it's entirely their responsibility. So these are all the challenges that the urban newborn faces, especially the newborn is premature, sick, or needs more specialized care. Can we have the next slide?
It's there.
Yes. So this was just a picture. Actually, I was just trying to emphasize in this picture that this is these are the conditions in which urban children have to live. And so you can see that their homes, as I said, the homes are made of material which is of poor quality. Clearly, there is no ventilation. There's no sanitation. They don't have clean drinking water. These are the reasons why they are more vulnerable to very serious health problems. Next slide, please. So after the birth of the baby, even if the baby is found to be well, or if there's an institutional delivery and the baby goes home, the doctor has said that this baby is all right. Even then, after the baby has gone home, some problems might emerge. So continuity of care is very important. But we don't have that much continuity of care. And some of the commonest issues we face, they are breastfeeding difficulties, the low birth weight, infections, vaccination related issues, and of course, COVID related concerns. We have to consider that these days in the middle of the pandemic. Can we have the next slide? So next, breastfeeding issues. Even though breastfeeding is not a unique problem of the urban setting, these kind of problems are happening everywhere. But this breastfeeding, the success of breastfeeding is so vital, it's so essential for newborn health that we have to discuss it. So breastfeeding, these issues, they commonly come up for all babies. And we find that there is, when the baby goes home, typically the mother has not received proper skilled breastfeeding counseling. So even if it's a big hospital, a tertiary level hospital or a medical college, the mother hasn't received proper breastfeeding counseling. So she comes, there is a faulty feeding technique, and so which results in pain, breast engorgement, and ultimately the baby is not getting enough milk. And what happens is that there is this pressure from society, not only from the family, but also sometimes from healthcare workers to start giving formula. And here there is another problem, that is these small homes. There are shared spaces. The mother is sharing space with other members of the family. There's lack of privacy. She can't breastfeed as frequently or as much as she needs to, or as the baby, as much of as the baby needs. Even if these problems are identified in the community, there's a lack of skilled counselors and there's a lack of skilled breastfeeding services. The easiest answer is usually to start giving formula or to start bottle feeding. Next one. Low birth weight. So the incidence of low birth weight is high in our country. And when a baby is born low birth weight, typically they have spent more time in the hospital. They have been more ill and the family is more anxious. Even if the mother comes home with the baby, there is a lot of uncertainty and fear about the baby's condition. So baby and low birth weight babies or premature babies manifest symptoms much less than term babies. So there is a late identification of illnesses. And sometimes mothers feel this baby is weak, so he's sleeping too much, he's not feeding. At the same time, she's missing out on some vital signs that this baby may have an infection or some underlying disease. And another very important thing that I've noticed is that the family who comes home with a low birth weight baby, who's a very small baby, they're just desperate that the baby should grow fast. And so they start formula feeding. Their threshold for starting formula feeding is very low. If somebody tells them that this baby hasn't grown, or if they have this feeling that even if there is this idea that this mother is not getting enough breast milk, then the formula feeding starts much earlier for preterm babies. And again, lack of privacy, big issue. Lack of privacy for a preterm baby. Not only breastfeeding, this baby needs KMC, kangaroo mother care. Is not going to get KMC if this mother is in a crowded room with others. And so the baby suffers as a result of missing out on the KMC. And as it is, there's difficult bonding. Baby has spent a lot of time in the hospital, mother has not been with the mother. And again, no, this KMC is not happening. Babies who are premature, they respond less. So these are very important reasons why preterm babies become even more vulnerable in a situation where skilled help is not available. Next slide. Next point was vaccinations. Even though vaccinations after the birth dose of the vaccinations, even though vaccinations are not strictly a newborn issue, because babies are vaccinated again after the age of 6 weeks after they come home. But even then there is, can we have the next slide, please? Okay. So after this baby has got the birth dose of the vaccination, we don't need to vaccinate till 6 months, but still there are some confusions, and often mothers and fathers or families are aware that the government sector doesn't give all vaccines. Some vaccines are not given, and then they are not, because they are not provided, they try to find out about those vaccines. Sometimes they spend a lot of money on these vaccines, and there is a lot of confusion about vaccinations. And sometimes parents can take the more expensive vaccines but neglect to take the more important ones like the MMR or the TPT. They have not taken. These things happen too. Next, COVID related issues. So COVID is now, even though even though now COVID is happening in rural areas, but COVID is still very much an urban problem. And we find that people are neglecting testing, even if they get fever, or even if they are symptomatic, or even if they are very close family contacts of people who are positive. So there are two scenarios that I commonly see. One is that people feel that, oh, this is a very mild illness, it's going to go away. Why should I spend 1,500 rupees to test? It's going to go away. There is this idea sometimes. And another thing is that there is also some families or some patients have such a fear of the diagnosis of COVID that they delay the testing because they just don't want to face the idea that they might be having it. They delay testing, and any kind of delayed testing can result in increased morbidity for the especially if the mother is the person who is symptomatic, or if close family members are symptomatic. So it can increase spread as well as increase morbidity. And again, despite having told the mother that even if she's COVID positive, she can still be with the baby, she can still breastfeed, skin to skin contact is still allowed. Even then, often families separate the mother and the baby. And of course, isolation and distancing in small homes, it's almost impossible. I don't know how it can be done. And in case, and there is another COVID related issue, even if the family has not got a member who is COVID positive, if the child falls ill, we find that there is no possibility of prompt access to proper hospitalization. As soon as you take the child to a hospital, the first thing that is being told is, oh, this baby needs to be isolated because we have to do a COVID test before allowing him into the ward. So now that is very reasonable, but sometimes the care of the baby suffers as a result of that. Sometimes what happens is that this mother and the baby both have to be in the hospital together. So they are both going to be needing a COVID test. As soon as both of them need a COVID test, parents are concerned about the cost of testing of two people. So, and these things become a very big issue for them. So these are all concerns that are related to this COVID pandemic and related to newborn health right now. Next slide, please. So to finally sum up one or two of the key things that I feel about the urban healthcare system here is that among the urban poor, the newborns at home are very vulnerable. They are vulnerable because of all the previous reasons. They are vulnerable to malnutrition, infections, and as a result of that, increased morbidity. And some large cities who have sufficient funds, they have better healthcare facilities than others. And referral services are available, but they are not organized. And if there are medical colleges and big hospitals nearby, then people who are living in that area, they are benefited. But there is generally, even if there is a facility available, there's no provision for outreach services, in the sense that nobody is, even if you know that this newborn needs a little bit of follow-up, there's no provision that a healthcare worker can go to the home of the person to see whether the baby is doing well, or even make a phone call to see whether the baby is doing well, or advise the mother on the phone if there is some problem. Maybe the person can advise the family or tell them to bring the child to the hospital. These services are not available. And as I said, there's no linkage, which is a big disadvantage. When the child is taken by the family to a hospital, there is no, he has been referred by a person A, but when he reaches hospital B, it's quite possible that he will be refused either treatment or admission, because he will be told either that there are no beds, or that there is, this hospital cannot treat this condition. These things happen often, even in the urban setting, when so many facilities are available. So that was my last slide. There's only one more slide. It's a picture. Thank you very much. I would like to say that let us not shut out our urban children. Let us together build the infrastructure that they need.
Thank you, Dr. Nina.
Thank you
so much. I think I really enjoyed your session. and you
Thank you
brought such
very
a good perspective on urban, and it many things were even learning from me. I think the participants have really enjoyed this perspective, and we also have a comment from Dr. Kananika that it was very practical and real problems in urban settings well highlighted. Thank you, Dr. Nina. I think
Thank you.
yeah, when we talk
Thank you
about
to
home
you
based,
and Sphere India.
thank you.
Yeah, what
So
you saying?
we spoke about home-based care at newborns from most of rural perspective. I think what urban challenges what Dr. Nina has put up, I think really it is eye opener and a food for the thought for all the policymakers and program managers also, and also how to bring the comprehensive primary health care in urban setting, because it is more spoken about in the rural setting, and try to address these challenges. So in despite of these challenges, we have few solutions. How can we quickly provide these newborn care services in spite of these challenges? That I request Dr. Subhashish Roy to highlight in his presentation. Over to you, Dr. Subhashish Roy. Meanwhile, I'll share your presentation.
So good afternoon, and it is really a fantastic presentation by Dr. Nina Ghosh regarding the public health aspect of the urban challenges regarding the newborn rearing. I basically will not go in detail with the public health aspect. Rather, I will talk about the specific problems which are faced by the. Can you please make a slide share mode? I will basically talk about the specific problems that are faced by the parents in the urban settings, and they have specific challenges. Now, India is a very vast and the population is a very big country with a very vast population, and there are a lot of heterogeneity in the population. And the heterogeneity is even more in the urban settings. Here you can get mothers who are driving Porsche and who have done PhD. Similarly, you will get mothers who cannot procure 2 square meals and illiterate. So there is no straitjacket solution regarding the urban healthcare so far as the newborns are concerned. So let us see what are the, Nina has already said regarding the challenges. Let us see what are the solutions we can think about. Now, the first point that Dr. Nina said is a problem regarding the breastfeeding. Yes, it is there. And as you know, almost 20 to 30% of the urban population attend the private hospitals. Many of them are big corporate hospitals or different nursing homes and different other private setups, where the gynecologists and the pediatrician who attend this labor are very busy. They don't have the time to attend the parents or counsel the parents for a very long period of time. So from the first day of the life, many of the hospitals, especially the corporate hospitals, they take the child from the mother and take away in the nursery, and the problem starts there. And the sisters or the nurses who are there, they don't have the time to counsel the mother, and almost 80 to 90% of the deliveries in a private nursing home are done by cesarean section, whereas in contrary to the private hospital, in the government hospital, almost 80 to 90%. Now it is close to 70%. The deliveries are in a normal delivery mode. So as soon as the cesarean section is being done, feeding bottle is being ordered to the sleep is being given to the parents with a feeding bottle and the formula milk, and the problem starts there. And it is how to mitigate this problem. It is a problem of the pediatrician and the gynecologist itself to be very sure that the mother is being given support, adequate support, and mental support also by the hospital staff and healthcare workers who are around during the 4 or 5 days stay in the hospital. Because if it is a cesarean section, the mother is there at least for 4 to 5 days. During that period, the mother is amply supported mentally and physically to continue breastfeeding. No bottle, no honey. Many of the families, there is still a system that after the baby is taken back to the to home, they immediately buy. Even the doctor has said no, but still they start giving bottle, because they think if we do not make the habit of bottle feeding from the day one, then the child will not be willing to take the bottle in their later life. Some of the families start giving honey, some of the families start giving syrupy solution, but all these things should be discouraged in a very important, very subtle way, and very strong message should be given to the parents. Second is improper latching. Again, the problem is that the healthcare workers hardly have any time to counsel the mothers. In the urban setting, there is enormous pressure on the healthcare, so they don't have time to counsel the mother properly. And lactation experts are there, but the number is very few. So it is a solution basically is to counsel the mother, counsel the father, how the proper latching is important, because otherwise, if the mother doesn't know how to give the breast milk properly, even if there is milk, the breast milk exclusive breastfeeding program will fail. Lack of examination of the breast during pregnancy, we have seen, and I see a lot of cases where after 1 week or 2 weeks or 3 weeks, the mother comes and say, doctor, my child cannot latch on because I have an inverted nipple, and nothing can be done at that point of time. So it is antenatally, these things should be checked by the doctors who are in urban setting, who are working in the antenatal clinics, or the healthcare workers. Non-supportive family, if the child, in many of the cases, the child cries at night, and maybe that due to colic, but most of the cases, the family thinks the easiest way to circumvent the problem is to give a bottle feeding. So instead of giving support to the very young mother or to the parents, the grandparents really do not play the right role. They always insist to give a bottle feeding. So again, here counseling not only the parents, the grandparents also is very important so far as the successful breastfeeding is concerned. And working mother, all of you know, in urban setting, there are different categories of mother who are working in the government setup, quasi-government, private setup, daily wages labor, slum dwellers. So not all the mothers get adequate leave. So not adequate amount of rest, not adequate amount of leave due to maternity. So many of the mothers had to join their job after, say, 1 month. So successful breastfeeding exclusively for 6 months is impossible proposition in those cases. So all these things have a solution. We should be compassionate. We should be considerate so far as the who are the employees. Allow the mother to have a proper rest and leave with pay till the child is exclusively breastfed till 6 months of age. Next. So yes, KMC, what Dr. Neena Ghosh has already said, the non-supportive family and inadequate knowledge, these two factors come hand in hand, because we, the urban doctors, have hardly the time to counsel properly what are the benefits, what are the correct techniques of the KMC. But there should be at least a leaflet in the solution can be simply handing over a leaflet or a flyer to the newborn, to the parents of the newborn. Or nowadays, almost all the parents have a smartphone. We can send this thing in the phone also through WhatsApp. What are the intriguing points of kangaroo mother care? And I have seen in most of the urban affluent families also, they don't know what are the features of kangaroo mother care. So it is not the poor who doesn't know, even the rich and the classy urbans also do not know what is kangaroo mother care. So it is not very important. It is not very important that they should be taught during the labor. If during the antenatal visits, these things are being taught exclusively to the parents or given some reading material, then it is extremely important. And the second very important is inadequate privacy. In slum dwellers or those families who are living in a single room living space in urban, because you know, in almost all the urban cities, there is a severe space crunch, and it is extremely expensive to have a 2-bedroom flat or 1.5 bedroom, even 1.5 bedroom flat. So where is the privacy? where the mother can sit with a bare chest. Even during the winter, she can cover herself with a light blanket or something, but she has to sit with a bare chest. Now, where is the space? How can you provide that space? So, to overcome this problem, just you can tell the parents or the family elder members to install a curtain in one corner of the room where the mother can sit with the child and can feed the child in the way of kangaroo mother care. This can be done without much expense, but with some motivation, this can be done. Next. So premature, almost 30% of Indian babies are born prematurely, and they have specific problem. What I have personally felt regarding the feeding difficulties for the prematures, many of the prematures are successfully reared up and successfully taken care in the hospital. When they are being sent to their respective home, they come back after 2 days with severe aspiration. This is quite a serious problem and quite a common problem. Now, the parents should be taught that these children are very small, very weak sucking ability. So the spoon size should be very small according to their size of the mouth. If that is very disproportionate, if you do not tell them, if the healthcare workers do not tell them this problem, then there is a high chance of aspiration. Prevention of infection is very important, and prevention of infection is very important for the prematures. And what can be done? We should tell the parents that hand washing is very important and no visitors should be allowed to enter the room and touching the child without proper hand washing. Warmth, again, eastern part of India, the winter is not that severe, but northern part it is very severe. So keeping the premature warm is a big issue, and here the kangaroo mother care is a very important. And to circumvent the problem of the hypothermia in children, in the prematures, the ensuring and encouraging KMC is very important. And we should not forget the special needs regarding their calcium, regarding the supplementation of vitamin D, multivitamins, and starting the iron in due time. So these are the special problems of the prematures. It is not only in the urban, even in the rural setting, the special needs are there, which should be started just after birth. Next. Next. So common ailments and how to manage. Yes, there are some problems in the urban settings, especially I have seen 3 or 4 cases in my life that jaundice has not been recognized at all because the rooms are so overcrowded. There is hardly any ventilation, any light in the room. The parents never see that the child has become severely jaundiced or too yellow. So at least the parents should be said that if you are you're dwelling in a room which is ill ventilated, ill illuminated, at least once you take the child out from the room in a daylight and see whether for the next 7 to 10 days after returning from healthcare facility to see whether the child is severely jaundiced or deep yellow skin discoloration. Lethargy, poor feeding, these warning signs should be told to the urban parents very clearly and categorically, because there is a lack of time. Because in the cities, the life is much more fast. The day that the child is returning home, the next day the father will be running for their livelihood. So what are the things that should be looked for? The mothers and the mothers and the parents and also the grandparents should be told in very categorical and a very crisp way that look for these things. And to check the weight is very important. And there are facilities where we can check weight, but there is again some problems is that there are some urban centers where the children, the newborn babies can be taken by the parents. But suppose in my locality, there is an urban center 800 meters from my house. But if you ask 100 people, where is the urban center? Nobody can say, because not there is a big hoarding, no direction on the roads, and no locality earmark is there where the urban center is located. So where the child to be taken. Now, another problem is that regarding regular visit to the clinic, healthcare facility is that if the parents stand in the long queue, like in government hospital, if you go, the 100 people are standing in front of you, you will lose the daily wages. In daily wages earner, in slum dwellers, which is unaffordable. So they don't take the child to the healthcare facility until and unless there is a very serious problem, the child is not sucking well. So that is a problem. So the urban centers should be earmarked. There should be a big hoarding, and on the streets, there should be a direction where the urban center is located. Hypothermia, there are very simple clinical clues. If the feet are cooler than the abdomen, then it is a mild hypothermia. But if the feet and the abdomen or the stomach, the temperature is below normal and both are cold, then it is a serious hypothermia again, which is much more severe in cases of northern part of India. In eastern part of India, the winter months are not so severe. The skin rashes are very important, and many of the time, in the urban settings or in some families, it is not only in the urban settings. In some of the families, the custom is to start massaging the child with mustard oil twice or thrice a day, and the mustard oil may be too irritant for the baby's skin, and the skin rashes come up. So avoiding kajal, avoiding bath for first 2 days in premature children, avoiding oil application for first 15 to 20 days. These things should be told categorically in children in the discharge certificate. Colics and gasiness, of course, this is a serious problem in many of the families where the father is suppose a daily wages earner or a laborer. When he returns home and the child starts crying in the midnight, then a lot of tussle starts bubbling up between the parents. And it is one of the causes of familial abuses. The mother is being, I have seen the mother is being beaten by the husband because she was unable to console the child, even after giving all sorts of breast milk, formula feed, everything has been tried, but the child didn't stop. And the father couldn't sleep, and he hit the wife. And so colics and gasiness, these are also very important things. And that also, what is a very basic, some antispasmodics, nowadays we don't encourage giving dicyclomine, but some other antispasmodics which are available, which are safe, can be safely prescribed with the discharge certificate. Next. Next. Now it is COVID time.
We need to quickly conclude, Dr. Subhashish.
Yes, this is my last slide.
Yeah.
It is a COVID time. So mother detected COVID positive just after delivery. Now this is a very common scenario nowadays we are seeing. And if the mother is positive, but there is no symptoms and the mother is fit enough, no point of stopping the breast milk. So you can continue the breast milk. Mother having fever for a day or two and the mother stop breastfeeding. But in viral illnesses or in common illnesses, there is no point of stopping the breastfeeding. So the breastfeeding can be continued. Many of the times we receive calls, mother taking tablet for headache, body ache, or any other pain in the body. Paracetamol is extremely safe while in nursing mothers. So no point of stopping the breastfeeding. Mother taking antibiotics for some cough and cold. Again, many of the cases, the parents stop breastfeeding because the mother is taking antibiotic. Again, that is not necessary. So because in urban setting, doctors are available around, so the chance of taking medication in the mothers are much more, and their antibiotics are prescribed freely in the cities to give a faster cure. But most of the antibiotics are very safe while in lactating mother. So the breastfeeding can be continued. Last slide, please. So giving a proper care in an urban setting is not a rocket science for the newborn. But again, these are the general words, which is not very specific for the urban mothers. But what is, I have in my 30 years of practice, I have seen an educated mother is a better mother so far as taking care of the newborn. Compassionate husband, even in hunter-gatherer stage, when the male used to hunt for their food, 30% of the male used to take care of the offspring, stopping the hunting and gathering. Supportive family is very important. Without a supportive family, you cannot get proper newborn care, and a sympathetic society. And this is very, very, very important. A sympathetic society only can give a proper nourishment and nurture for the newborn. And very well informed pediatrician is also very, very, very important, because in urban setting, in many of the corporate hospitals, the failure of breastfeeding starts by the advice of the pediatrician who advises for a formula. And if the pediatrician is well motivated, well informed, then we can continue for a successful breastfeeding for 6 months. Thanks UNICEF and thanks Sphere India for inviting me in this program. Thank you so much.
Thank you, Dr. Subhashish. That was a wonderful presentation. We don't have much questions. I'll take one last question for Dr. Neena. Dr. Neena is there?
Yes, I'm here.
Yeah, there is one question in the chat box. Do we have a to provide this adequate counseling, breastfeeding for the mother?
Pardon, I lost you for a moment there. Can you just repeat that question?
Yeah, do we have adequate lactational counselors in the private sector? Is it a challenge?
No. We don't have proper adequate numbers of lactation counselors. We really have to build up that resource, because lactation counseling is, and there is a lactation counselor does not necessarily have to be either private sector or government sector. It is just a person who has the requisite skills to be able to provide skilled counseling to mothers for breastfeeding, to mothers and even families for breastfeeding. And we really don't have adequate numbers.
Can I come in, Neena? There is only 2 lactation experts in Calcutta, in 2 corporate hospitals, one in Peerless and other is somewhere else, I do not remember, maybe in Apollo. In Calcutta, we have only 2 lactation experts or lactation counselors who can counsel the newborn babies and the parents. But the number is very few and it is completely inadequate so far as the total number of children born.
Thank you, Dr. Neena and Dr. Roy. That was a wonderful presentation.
Thank you so much.
Participants, kindly bear with us. I just want to confirm from Dr. Samir from SHRC. Is Sunita ji still there with us?
Yeah, Sunita ji is here.
Yeah, participants, bear us for next 3 minutes. Sunita ji is waiting for us for a long time.
Sure.
Sunita ji, please, आप अपना experience share करिए. सुनीता जी, आपको सुनाई दे रहा है?
जी।
हाँ, प्लीज बताइए।
रायपुर क्षेत्र से।
हाँ, सुनाई दे रहा है सुनीता जी, आप बात करिए।
जी।
हमको सुनाई दे रहा है।
मैं सुनीता धनगर बोल रही थी, मितानिन। मैं करीब 100-150 घर देखती हूँ सर। हेलो।
हाँ, बताइए, हमको सुनाई दे रहा है, बताइए।
जी।
आप बोलते रहिए, आप सुनाई नहीं देते तो मैं आपको बता दूंगा।
जी। हम नवजात शिशु के बारे में देखने जाते हैं मितानिन लोग, और संक्रमण की पहचान करते हैं। उनके जाना कुछ पूछेंगे नहीं?
आप बोलते रहिए, बस पूछेंगे तो उधर से पूछेंगे।
सुनीता जी, आप बात करिए, हम सुन रहे हैं। आप जो घर जा रहे हैं, तो घर पे जाके क्या करते हैं आप?
घर पे जाके नवजात शिशु को संक्रमण की जांच करते हैं सर हम लोग।
हाँ, आपको ये सब आता है जांच करने के लिए? कौन सिखाया आपको?
हमारी एमटी सिखाई है और हमने ट्रेनिंग भी लिया हुआ है।
हाँ।
तो
अभी आप कॉन्फिडेंट हो करने के लिए?
जी।
कोई मुश्किल नहीं आता है आपको?
नहीं होता है सर वैसे, और होता भी है तो हमारी एमटी साथ में भी रहती है, फोन करके पूछ लेते हैं।
हाँ
जी।
तो आप कितने महिलाओं को देखते हैं एक महीने में, या हर बार जब विजिट करते हैं आप?
ऑल महिलाओं को देखती हूँ सर, बच्चा को भी देखती हूँ, और अन्य और भी हैं जो मदद करते हैं हम लोग मितानिन लोग। ऐसा ही नहीं है कि बच्चा हो, पूरे परिवार को हेल्प करते हैं हम लोग।
मुश्किल नहीं होता? आपको घर का भी काम करना होगा, उसके साथ साथ ये भी काम करते हैं आप?
नहीं होता है सर।
आप टाइम निकाल पाते हैं?
जी।
ऐसा कोई बच्चा है जो आपने देखा था बहुत कम वजन था और आपने उसको ठीक किया है और या रेफर किया है? ऐसा कोई अनुभव शेयर करेंगे आप आपका?
जी, है ऐसा बच्चा।
बताइए।
अभी 2 साल पहले मेरे एरिया में 1300 ग्राम का बच्चा पैदा हुआ था।
हाँ।
तो उस बच्चे को
ये घर में पैदा हुआ था कि अस्पताल में?
अस्पताल में ही पैदा हुआ था।
ठीक है।
उसके बाद में फिर उसको हॉस्पिटल में 1 हफ्ता रखा गया, फिर डिस्चार्ज कर दिए उस बच्चे को, और घर में फिर उसको फीडिंग के लिए अपन रोज जाते थे घर में। घर में ही।
तो आगे कैसा वजन बढ़ा बच्चे का? कितने दिन में बढ़ा?
बच्चे का वजन करीब 2 महीने में 2.5 किलो का हो गया बच्चा। उसके घर में नर जाती थी, 4 से 5 बार जाती थी दिन में।
तो अभी कैसा है बच्चा?
अभी बच्चा बहुत बढ़िया है, आंगनबाड़ी स्कूल में खाना खा के आ रहा है, पढ़ाई करके आ रहा है अभी।
बढ़िया बढ़िया, बहुत अच्छा काम आप कर रहे हैं। और कुछ बोलना चाहते हैं आप? हमारे बहुत सारे एनजीओ आती है हमारे इधर।
और परिवार भ्रमण के लिए हम जाते हैं तो ये वाली पुस्तक लेके जाते हैं अपन।
हाँ,
ये वाली पुस्तक को साथ में लेके जाते हैं।
क्या है उस पुस्तक में?
इस पुस्तक में नवजात बच्चे की देखभाल।
ओके। तो आप अगर कोई बच्चा तकलीफ वाला पता चल जाता है गांव में, तो आप क्या करते हैं आगे?
तकलीफ जिस प्रकार का बच्चे को तकलीफ है, जैसे कि निमोनिया हो गया सर बच्चे को।
तो कैसा पता चला आपको निमोनिया हो गया?
निमोनिया अपन सांस की गति तेज करते हैं, सर्दी खांसी वाले बच्चे के यहाँ जाते हैं अपन। और सर्दी खांसी वाले बच्चे के यहाँ गए और बच्चे को उम्र के हिसाब से उसकी सांस की गति देखते हैं सर। सांस की गति पता चलने पर एमॉक्सिन का पहला डोज देकर उसको हॉस्पिटल रेफर करते हैं।
वेरी गुड। सो आपको सांस की गति देखने भी सब सीखा है, अपने आप सीख रहे और निमोनिया डिटेक्ट कर रहे हैं आप?
जी जी जी।
वेरी गुड। और कहाँ पे रेफर करते हैं आप?
ये अपने एरिया का प्राथमिक स्वास्थ्य केंद्र में या फिर जिला हॉस्पिटल, 2 जगह करते हैं।
ओके ओके। और जाते हैं वो आप जब बोलते हैं?
जाते हैं सर, और कई जने लोग असमर्थ भी रहते हैं, नहीं जा पाते हैं, तो उसको एमॉक्सिन का अपन 7 दिन तक दवाई देते हैं, एमॉक्सिसिलिन का दवाई।
थैंक यू सुनीता जी, बहुत बहुत धन्यवाद। हमारा टाइम अभी कम हो रहा है तो हम अभी संवाद इधर ही खत्म करते हैं। Thank you so much. Dr. Samir, you can just mute Sunita ji. So this was what we spoke with Sunita ji. I think for the non-Hindi audience, Vandana is requesting me to translate. So Sunita ji works as a Mitanin in Raipur district. So she says that she does home-based newborn care. So you can also understand what the way she was speaking. So she has been trained to do home-based newborn care, trained to diagnose the danger signs, and also give the first dose before referral. So she quoted also an example of a child which was born 1,300 grams and discharged from the hospital. And she took care at the baby at home itself, and the baby did not need any further hospitalization. And the weight increased from 1,300 to 2,500 gram in a span of 2 months. She also quoted an example where she diagnoses pneumonia by seeing the age-specific respiratory rate. Shows she has been trained to look at the respiratory rate as per the age if criteria. If it is more than that, then she knows that it is pneumonia, and she is giving the first dose of amoxicillin and referring. So this is the inspiring story from the Mitanin. So what we heard from the experts that this is possible, I think we have a real example in the name of Sunita ji, and there are thousands of such Sunita ji in our village level working as ashas and providing this home-based newborn care. So to conclude, I will say that summarize the entire session, the care of newborn definitely is very essential, and the care should not be restricted to the health facility, but it should be continued at the community, at the home as a continuum of care. Mother needs support, but it should not be restricted there, but the danger sign should be diagnosed at early, and there should be seeking of hospital care. And as Dr. Reena told, that there should be a definite referral linkages from home to community and back to facility and back to community from facility. Comprehensive primary health care is the most cost-effective approach for providing solutions for all the problems we are facing. Along with that, we should not forget we need to start recognizing the urban challenges and also design our programs accordingly. I hope this session will motivate a lot of our audience. We reached almost audience for 150, and almost till last 10 minutes back, we had participants more than 100 continuously for this session. Thank you participants for joining this. And I hope more of the civil society organizations who are part of this webinar as participants will be motivated after this session to work in the area of newborn care. Thank you. Thank you for all the panelists. Dr. Pavitra Mohan, Dr. Sanjay Prabhu, Dr. Amar Singh Thakur, Dr. Samir Garg, Sunita ji from Raipur as Mitanin, Dr. Reena, Dr. Neena, and Dr. Subhashish Roy. Thank you. Thank you so much for giving time, and apologies that we overshooted what was, but I never felt that we are overshooting. It was so interesting and engaging. Thank you. Thank you one and all. Over to you, Thomas, if any last remarks.
Yes, sir. Indeed, it was a blessed opportunity for me to attend this session. So I would just like to thank Dr. Sridhar Rayavanki for the incredible and effective moderation of the session. And also we thank each and every speaker and all the participants for such an enriching discussion. Before we end the session, I would like to mention a few administrative directions. Your certificates will be ready in 24 hours. You can visit our website, www.spearindiacovid19academy.org, and you can download your certificates by scrolling down and finding the name for today's session. It will be ready to download in 24 hours. However, if you are unable to do that, as some participants have faced technical difficulties, do not worry, you can email us at covid19academy@spearindia.org.in, and we will get back to you as soon as possible. Have a great evening and see you for the next session. Thank you all.
Mr. Thomas, anything about the presentation sharing? Will it be shared on website, or how it will be shared?
Yes, sir. Definitely, we would be uploading all the documents which we shared on this platform will be uploaded in our website within 24 hours, along with the certificates. So all the participants can reach out to our website and download it from there.
Thank you. Thank you, Ananda.
Thank you all.
Thank you, everyone. I'm leaving.